Ladies and gentlemen, greetings to all of you. It is indeed a privilege for me to be addressing this gathering of exemplary TB champions. It's really inspiring to learn about your journeys, experiences, and efforts to fight this infectious disease which continues to affect millions of our people. Recognizing the deep social and economic impact tuberculosis has on its patients, the government led by Honorable Prime Minister Shri Narendra Modi ji has accorded high priority for ending tuberculosis in India by 2025, 5 years ahead of the Sustainable Development Goals target of 2030. In recent years, India has taken several critical steps to emerge as a leader to chart the roadmap for a TB-free world. Our National TB Elimination Program has drafted an ambitious national strategic plan to achieve the Sustainable Development Goal target related to tuberculosis by 2025 and is being implemented accordingly. It embraces bold strategies with commensurate resources to rapidly decline TB incidence and mortality. We have enhanced access to molecular diagnostics by decentralizing CBNet and TrueNet services, enabling earlier detection of drug resistance. Through active case finding, India has reached out to the unreached and vulnerable groups. We are committed to scaling up access to free diagnosis through rapid molecular tests and providing free treatment for all TB patients using best quality drugs and regimes, along with providing financial and nutritional support. National TB Elimination Program has instituted many innovations such as contracting of patient-provider support agencies to enhance engagement with the private sector. Through integration of TB services with Ayushman Bharat, the largest comprehensive healthcare and health protection program in the world, TB has been made an essential part of comprehensive primary health care. Sub-national surveillance of TB and disease-free certification has been introduced, wherein states and districts that have achieved significant reduction in incidence of TB from 2015 baselines are being assessed and awarded bronze, silver, gold or TB-free certifications. To strengthen community engagement, TB forums have been established across the country, which provide a common platform to government officials, physicians, civil society and representatives from patient groups to discuss all concerns pertaining to service delivery and patient care. I would like to highlight that these bold commitments are also being backed by affirmative action, policies and resources. Resource allocation for TB has witnessed a substantial increase in recent years. Last year, the government has disbursed more than 249.43 crores to over 11.10 lakh patients as nutrition support under Nikshay Poshan Yojana. TB elimination efforts did see a few setbacks with the onset of COVID-19, like case notification in March 2020 decreased by 21% as compared to January 2020 due to lockdowns, but as soon as it was lifted, we have managed to cover much of the lost ground and were able to notify a total of over 18 lakh TB cases in 2020. While this has been a difficult time for all of us, prompt decisions and constant advisories issued to states largely resulted in provision of uninterrupted services to TB patients. We have issued guidelines for bidirectional screening for tuberculosis and COVID, and also initiated screening for TB among cases of influenza-like illness and severe acute respiratory illness. Friends, considering the extensive TB burden and the gamut of challenges, we must agree that much more needs to be done with support from all stakeholders. To address tuberculosis, the first step is that we need to stop thinking of biomedical solutions only. TB is a social disease. I strongly believe TB control needs to be taken up by all of us as a developmental issue. We have called upon a Jan Andolan against TB to reinforce our commitment to end TB through multi-sectoral and integrated actions. Just this week, recognizing the leading role we have been playing in tackling TB, India has been asked to take on the role of chair at the Stop TB Partnership. I am honored to represent our country in the capacity of chairman of the partnership and to work with TB champions across the globe to steer efforts towards eradicating this disease globally. This will further help in the exchange of best practices and knowledge among all stakeholders, while also integrating and reinvigorating global efforts to effectively address this grave health hazard by making it a people's movement. Before I conclude, I would like to place on record my immense appreciation for Survivors Against TB for holding this crucial India TB Summit. I am confident and optimistic that with the continuous support of organizations like yours and through collaborations across all sectors, India will be able to conquer the battle against TB and achieve the target of ending tuberculosis by 2025. Thank you for giving me the opportunity to address this esteemed gathering. I wish India TB Summit a grand success.
Hi everyone, welcome to day 2 of the India TB Summit. I am Dr. Anand Bhan, a researcher in global health, bioethics and health policy, and I will be co-chairing this panel on mitigating socioeconomic determinants of TB care in India with Ashna Ashish. Welcome to all the participants of the summit to this crucial panel. So why this panel? You know, as a country, we've been struggling with its TB burden, which is the highest in the world. And sometimes in the conversations around TB control, it is often easy for us to get lost in a focus on screening, on diagnostics, on treatment, on surveillance, etc., without recognizing that there is also a need to look at the social determinants of the disease. Now, tuberculosis has often been characterized as a disease of poverty, of vulnerability, of marginalization. And this does, of course, also often manifest in stigma towards the disease and those who have it. Yet, when we talk about the disease, we usually only address the clinical determinants of TB in India, ignoring the social and economic realities of patients that affect their health and their access to TB care. So through this panel, we want to highlight how mitigating social and economic determinants is critical to removing barriers to access to TB care in India and also to improving the quality of TB care. And why this, we hope, needs to be centered in our disease control, in our response systems, and our policy discussions. In constructing the panel, both the co-chairs, that is Ashna and I, have wanted to pull together expertise and perspectives which combine academic insights, lived experiences, unique perspectives, and bringing in intersectionality as well as pathways from a legal advocacy and policy perspective. And hence, we have curated this panel of speakers for this session. Our first speaker will be John Reyes, who is a development economist and an activist, currently visiting professor at Ranchi University. He is also a TB survivor who has had the disease twice. John will be reflecting on the social context of TB in India and will set the stage for this panel by sketching out the broad contours of this topic. Our next speaker would be Madhvi Bhargav, who is a faculty member at Yenepoya University in Mangaluru in South India. Madhvi has worked as a clinician in tribal Chhattisgarh for many years and is now conducting research on the role of nutrition support for TB-affected households in Jharkhand. Madhvi, through her presentation, will help us understand how there is a cyclical relationship between poverty, undernutrition, and TB, and what are the pathways to address it, and what is some of the work that they've been doing to try to illustrate this through a research project. Our third speaker is Ashna Ashish, who is also the co-chair for this panel. Ashna herself is a MDR TB survivor, a lawyer, and a public health professional who has been working on gender and TB, on mental health, and TB and patient support. She has indeed written extensively on these issues for various platforms. Ashna will be focusing on how to make TB care in India gender responsive, which we feel is an important component to highlight. Our final speaker for this panel is Anand Grover. Anand is a designated senior advocate practicing in the Supreme Court of India and is also the director of the HIV/AIDS unit of Lawyers Collective in India. Anand, in his presentation, is presenting a case study that demonstrates the role that legal advocacy can play in advocating for better access for drugs to drugs in various contexts. There are lessons to be drawn from this in how we can also use legal advocacy in the context of addressing socioeconomic barriers to TB care. Over to our speakers.
Friends, let me begin by welcoming this TB summit and also the work of survivors against TB. I am a TB survivor myself, in fact, a double survivor. I had TB twice. And I was looking back yesterday at the diary that I was keeping in 1984 when I had TB for the first time. It was a surprisingly simple affair. I was living at that time in a village of Uttar Pradesh called Palampur. And one morning I found myself spitting blood. And so I looked at a book that you all know of, I'm sure, called Where There Is No Doctor. And I found that I had many symptoms of TB. So I went to a local charitable hospital run by the Arya Samaj, and I was diagnosed with TB. So I procured the necessary drugs and then returned to Palampur and more or less went back to work. From this experience, I learned that recovering from TB, at least in non-drug resistant cases, is not a big deal, at least for somebody who knows what to do, who understands the disease, and who has the will and the means to do it, including taking rest and good food. Now, that, of course, is not possible for everybody. It is often said that TB is a disease of poverty, and one aspect of that is that the prevalence of TB is about 4 times as high among the poor as among the rich, as according to the National Family Health Survey data. This is a comparison between the poorest quintile and the top wealth quintile. But perhaps more importantly, another aspect is that it is much harder for a poor person to get over TB, especially if he or she has little education. And perhaps that is what the physician Edward Trudeau meant when he said that there is a rich man's tuberculosis and a poor man's tuberculosis. The rich man recovers and the poor man dies. That is, of course, a simplification, but there is an important element of truth in it. So TB is definitely associated with poverty and also with lack of education, That much is clear, for instance, from National Family Health Survey data in India. Beyond that, not much can be taken for granted. For instance, the association between TB and gender in India seems very puzzling. If you believe the National Family Health Surveys, then the prevalence of TB was much higher for men than for women in 2005 at the time of the third National Family Health Survey. And then in the 10 years that followed, the prevalence of TB among men declined quite substantially, while the incidence of TB among women increased, so that the ranking was reversed by the time of the fourth National Family Health Survey, when the prevalence of TB was higher, much higher, in fact, almost double for women than for men. This is quite surprising. And similarly, while it's perfectly understandable that the prevalence of TB is highest in Bihar amongst all the major Indian states, it's less easy to understand why Kerala comes in second position, despite having relatively high levels of income and education. So I'm hoping that other speakers will shed light on some of these patterns. There is, of course, evidence of robust associations of some kinds. For instance, there is a clear association between not only poverty and education and TB, but also good nutrition. Undernourished people are more likely to get TB and also more likely to find it difficult to recover. And since the purpose of this summit is to discuss ways of providing better care to TB patients, I would say that one possibility is to provide better nutritional support to them, or at least an option of nutritional support. I think there are already some initiatives being taken in this regard, but perhaps you can think of what more can be done. I don't think we can count on the public distribution system for this purpose, because the PDS in India is still almost entirely focused on wheat and rice, and that will not be of much help to most TB patients unless they are so poor that they don't have any food at home. I would not count on cash transfers. I hear that there's a scheme of cash transfers called Nikshay Abhiyan or Nikshay Yojana for TB patients, but I don't think that is likely to translate very well into better nutrition. And I also would be worried about the transfer being made through the Aadhaar-based DBT payment system, which has proved so unreliable for so many other welfare schemes in India. One option would be to allow TB patients to share the cooked meals at the local Anganwadi or school, but that would create a risk of infection, and I think one should be very careful with that. So I suppose it would have to be some form of take-home ration system, either take-home cooked food or food that the patients can take home and eat at home. That, I think, could perhaps be done through Anganwadis. It would require some coordination between the Anganwadi centers and the health department, but that is already happening in many states, and so it's not an impossible thing to do. We need, of course, also better nutrition for the population as a whole. That would also help to contain and prevent the spread of tuberculosis, but that is a much larger subject, and since my 7 minutes are already over, I will stop here and once again welcome this summit and look forward to the deliberations. Thank you.
Thank you, organizers, for giving me the opportunity to speak at the Survivors Against TB India TB Summit. Hello, everyone. I will be speaking about the addressing the cycle of poverty, undernutrition, and TB in India. As medical professionals, we are too busy seeing the medical aspects and at times even fascinated by the scientific advances. There's a real danger of tunnel vision, concentrating too much on drugs and the bugs. Also, some may ask, what can we do about the social aspects? A lot. Being sensitive to the patient and their predicament and making our programs pro-poor is a start. If I would ask you to guess the age of the patient with the X-ray that I'm showing, I don't think you will be able to come up with the right age. She's just 12 years old and she's a household contact of patient with pulmonary tuberculosis. And this is her second episode of the illness. She is one of our participants in the large cluster randomized trial called Rations trial being conducted in 4 districts of Jharkhand. In this trial, we are trying to see the effect of food rations on incidence of TB in household contacts of patients with pulmonary TB. Why should a child just 12-year-old have an extensive disease like this, and that too a second time? So poverty often determines who gets the disease, who gets infected first of all, progresses to disease, gets diagnosed and treated, and what outcomes happen. There is overcrowding, higher background prevalence of disease, poor ventilation, and indoor air pollution in poorer communities, which increase the risk of infection. We all know that TB infection is necessary, but not sufficient to cause the disease. The disparity determines the vulnerability. And once the disease sets in, not everyone gets the care immediately. There are diagnostic delays, difficulties in getting attention even after reaching the facility, and linkage to care. A care that is comprehensive to include all the comorbidities, including undernutrition, anemia, etc. The side effects get amplified due to undernutrition and alcohol, and social distress may lead to migration, and the result is poor compliance. Finally, if it is poverty that decides the catastrophic costs, deaths, job loss, and ability to go back to work. And due to clustering of cases in a family, the whole family gets pushed into extreme poverty. The 12-year-old girl's X-ray tells a story of poverty, the cycle of poverty, tuberculosis, poverty, and more tuberculosis, a cycle that is operating in millions of poor households in India. Thus, the disease is more prevalent, difficult to treat, and more illegal in the backdrop of poverty. If we continue to focus on biological causes and do not consider the material conditions of living and inequity in health access, we will continue to battle with poor outcomes. Outcomes both at individual level and at population level. This is a recent modeling study to see the impact of social protection and poverty elimination on TB incidence. Under the Sustainable Development Goal 1, the authors found that global TB incidence can reduce by 33% if we are able to end extreme poverty by 2035, and by 76% by expanding the social protection coverage. Both together will result in reduction by 84%. Now just keep this bit of information aside which I will refer to it again in my coming slides. Undernutrition and poverty are inseparable, but the debate on TB nutrition revolves around these common questions. Is it a cause or an effect? Is it a risk factor or is it a comorbidity? Is it biological or social? These are false dichotomies, as undernutrition can be a cause as well as an effect. It is a risk factor for population, but comorbidity in a particular patient, a phenomenon which is biological, but whose distribution is socially determined. When we first published the nutrition status of our cohort from Chhattisgarh of around 1,700 patients, in 2013, we were told that this is region-specific. Later in 2016, the national level data reported comparable weights. And most unfortunately, even now in our Jharkhand trial, the Rations trial, we continue to see similar weights in BMI. The debate around TB and nutrition has been complicated by the Cochrane reviews. The food support trials were far and few to prove any benefit on mortality, cure, or treatment completion. There were more trials on micronutrients, about 24, no visible benefits. This is understandable because micronutrients in the backdrop of inadequate food intake is not likely to be beneficial. We eat foods and not nutrients. This insufficient research and lack of evidence has been driving the policy, but the lack of evidence is not equal to no evidence. There have been observational studies to show that undernutrition is associated with more severe disease, leads to drug malabsorption, higher incidence of drug toxicity, especially hepatotoxicity, and relapses later. Continuing with the evidence space, let us compare these two interesting trials, one on isoniazid preventive therapy in latent TB infection and the one on vaccine. The IPT trial with mass screening and treatment for LTBI did not have any significant effect on control of TB in South African gold miners. Similarly, vaccine trial did not have significant efficacy against TB in infants. Now compare this with the Papworth socio-medical experiment in the pre-BCG, pre-chemotherapy era. This was not strictly a trial. There were social interventions like housing, employment, adequate food for the families. It reduced TB incidence in child contacts, almost 82% reduction. Isn't this comparable with the modeling study that I just talked about? There is a strong, consistent log linear relationship with TB incidence and BMI. Almost 14% reduction with each unit increase in BMI. So there have been several initiatives at national level. We have adapted the WHO guidelines to Indian context for nutrition care in support of patients with TB. There's NTB app to simplify BMI calculation and classification with key action points for frontline care providers. And lately, the direct benefit transfer of 500 rupees per month. But there are some other things that can be done. We can link patients with other existing benefits and schemes according to their age group and social situation. It will add to the support systems during a very vulnerable phase of their life. Appropriate advice on how to use the DBT. We cannot have our patients spending on expensive supplements and protein powders when there are better alternatives. There are certain areas in PMJ that can be leveraged for TB, specifically the inpatient care, investigation and evaluation of EPTB, which can be very expensive, and management of certain comorbidities like undernutrition and diabetes. While DBT is a welcome move, it is not adequate for patients with very low BMI. So extra food support till they reach functional status and productive status is very crucial. Inclusion of pulses in PDS probably will cover many other nutrition problems. We can extend the midday meals to late adolescent stage. And lastly, we do not have any preventive therapy guidelines as of now for household contacts of patients with MDR and XDR. So the household contacts can be given food support as a preventive measure to the very least. Thank you so much for your kind attention.
Good morning. I'm Ashna Ashish. I'm a public health professional, a lawyer, an MDR TB survivor, and I'm associated with Survivors Against TB. I'm here today to talk about how we can make TB care in India gender responsive. So to begin with, let's look at what gender responsive care is. Gender responsive care is basically care that is inclusive and equitable, and it caters to the varying health needs that differ across different gender and sexual identities. But why is this important? Why is it important to have gender responsive care? Gender and sexuality not just mediate the access to healthcare, but also affect it. So the LGBTQI++ community in particular is vulnerable in this context because they're abused, stigmatized, and discriminated against by the health system. Because the thing to understand is these health systems don't exist in vacuums. They exist within the same oppressive and discriminatory structure of society, and more often than not, they tend to mirror them. In our work at SATB with the LGBTQI community, we have heard stories where people have preferred the suffering of an illness, and in some cases even death, over approaching the health system for care. So there's a human cost to not providing gender-responsive care. And this cost, the burden of it, is being borne heavily by members of the LGBTQI community in particular. Look at the limitations of our current efforts in India. So the NTEP has the National Framework for Gender Responsive Approach to TB in India. This is something they've framed and put out. And while this is an important first step in thinking about gender-inclusive care in TB, there are certain limitations to this framework that are largely emblematic of the limitations that exist in TB care when it comes to gender. One one of the first things is a non-inclusive constitution of the framing committee. Now, we often say the means justify the ends, but as Gloria Steinem says, the means are the ends. So if your end is to create a gender-responsive framework, the means for that cannot be a framing committee that is constituted almost exclusively by cis hetero men and women, with the exception of one transgender person being included, because this amounts to denying a vulnerable demographic the right or the say in decision-making about the kind of care that they will receive. The language used in the framework in certain cases tends to reinforce stereotypes. Now, I realize that this is subjective, but if you look at the number of times they have mentioned men and women living in squalor or abusing substances versus the number of times they identify this behavior with transgender persons, you would be left with the feeling that somehow this is an endemic problem in the trans community, more so than other genders, whereas that is not the case, and there is no data substantiating this evidence in the framework. But what this does, though, this kind of careless language, is it perpetuates the stereotype then that influences care behavior, and in kind of reinforcing the discrimination stereotypes around these communities. The third problematic aspect is that it ignores the interplay between gender and sexuality. Now, the framework has made a conscious decision to separate gender from sexuality. So they cater to men, women, and to some extent to transgenders, but they've largely left out the lesbian, gay, bisexual, intersex, queer, asexual, and other plus minority populations. And this is problematic not just because gender and sexuality, when it comes to the context of health, are intrinsically linked, but this also means that in a country like India, which has the third highest burden of HIV/TB co-infections, of which members of this community tend to be more vulnerable to, you're leaving an entire vulnerable population outside of the ambit of care. The theoretical foundation of rights-based approach, again, is missing in this framework. There's very little that goes into informing it conceptually and then sort of using that foundation of a rights-based approach to then make these interventions, therefore diluting the kind of claim that any care recipient would have under such a framework. The interventions they propose are rather generalized. It's a very one-size-fits-all approach, which speaks more to gender-blind frameworks than it does to a gender-responsive framework that is supposed to look at the specific needs of a certain gender or sexual minority and then cater to those needs. For instance, while it does talk about trans persons, it entirely leaves them out of prevention and detection activities, talking only about men and women in the context of those activities. And this is just one example. Now, how can we make TB care gender responsive? I think the first step would be including and integrating the LGBTQI community, not just as community members in the process of developing these care frameworks, but also as health personnel in health systems that implement these care frameworks. And the next would be a rights-based approach. So the PHFI 2014 study actually that looks at how the what's now the NTEP, but the RN was then the RNTCP, actually says that this is an ideal case study of a gender-blind program, because while TB is a gender disease, the TB program does not sort of cater to varying health needs, and neither does it take a rights-based stance, which would allow for more accountability for care recipients. It's much more easy to hold a person or an authority accountable under a rights-based framework as opposed to a policy framework. And the framework itself talks about how there isn't enough data in the context of the LGBTQI communities. And this is a real problem, which is why to address this, when the TB program is collecting data, gender considerations need to be factored in. TB research needs to prioritize LGBTQI++ health needs so that the sort of data and evidence then informs the care, and we're giving them care that is relevant to their needs. Now, when we look at training and sensitizing health providers or like doctors or health workers or nurses about LGBTQI++ health needs, that to me is the curative side of the intervention. But like we do in dealing with any epidemic, we focus on preventive and curative activities. And the preventive aspect in this context would be to actually integrate LGBTQI++ health issues in medical school curriculum, so that you have medical students who are then trained to be gender responsive doctors, and then sort of reinforce that training then once they become doctors, so that you have both sides of the equation taken care of. We should also not forget that over 60% of Indians seek care in the private sector. So to maximize reach and leverage this reach of the private sector and the infrastructure, it is important that we conceptualize providing gender responsive care in partnership with the private sector across the country. Training health personnel to treat LGBTQI plus persons with empathy and dignity. So one way to do this, of course, is to appeal to humanity and talk about how it's important to treat other human beings with respect. Another pragmatic instrument that needs to come in, the cost of an institution not having gender inclusive or responsive care policies needs to be very high. That cost of compliance, the cost of sort of not meeting those standards should be placed on institutions so that they have some incentive to sort of bring in gender responsive care policies. The last is that when you look at members of the LGBTQI++ community, they are often discriminated against because of their identity. And that means they usually do not have access to stable incomes because they're discriminated in job settings. They don't have access to safe housing. They don't have access to adequate nutrition often. And on account of their identity, their families often choose to not support them. So they need social support both at the preventive level when we're talking about the determinants of health in terms of access to safe housing, access to adequate nutrition, opportunities for employment, and at the curative section where TB patients would need support for adherence, for nutrition, for mental health counseling. So this kind of support targeted to this vulnerable community has to be provided through the government programs. What you see on the concluding screen are actually the questions that we were asked by an LGBTQI++ respondent. She said, why do I get harassment instead of treatment? And how many more of us need to die while hospital staff is too busy arguing over who will treat us because no one wants to touch us before they realize our lives matter too? And we didn't have an answer to her questions, but what we did realize is that gender and sexual minorities in this country, of course, they suffer from illnesses, but they suffer more so because of the apathy of our health systems. And any framework, any gender responsive framework that does not place its most vulnerable community at the center, which in this case is the LGBTQI++ community, is neither gender responsive and nor inclusive. So when we're reimagining TB care, we need to make that process of reimagination a more inclusive process, so that the end result of that is a gender responsive approach to TB care in India. Thank you.
India has a huge and disproportionate burden of persons living with TB, about 2.8 million out of the total about 10.4 million in the world. That's nearly 27% of the total burden in India. Out of the total people living with TB, about 23% are MDR, and of the MDR, 6% are XDR. Maharashtra and Mumbai have the highest burden. Historically, treatment for TB was discovered in 1940s, but after that, there has been a huge upsurge in what is known as resistance TB and drug-resistant TB. So there are different types of drug resistance, which I'm not going to go into, but they include isoniazid, rifampicin, with one or two drugs, pre-extensive TB, that is XDR, or MDR TB, with additional resistance to either a second-line injectable agent, capramycin, kanamycin, or amikacin, or a chloroquinolone, and also fluoroquinolones, or one more of the second-line injectable drugs. However, now we have a very good scenario in terms of treatment. There are two drugs, bedaquiline and delaminate. Bedaquiline actually has been recommended by the WHO in 2013. The Apex Committee in India approved bedaquiline in 2014. The NTCD guidelines actually also approved in 2016. Initially, it was on 6 sites. And in 2020, the guidelines of the WHO recommend for a shorter all-oral bedaquiline-containing regime for 9 to 12 months. The guidelines on programmatic management of drug resistance, PMDT, also recommends bedaquiline to all MDR patients as a core drug because it has less side effects among the secondary drugs. Delaminate also has been approved and recommended by WHO in 2014. In 2017, India approved Dilaminid for MD or XDR TB in conditional use. 2018, RNTCP guidelines were issued for Dilaminid to be included in MD or XDR TB. Initially, it was provided in 21 centers across the country. And ultimately, in 2019, WHO recommended Dilaminid for treatment of children of 3 years and above. In India, it's of course only for 6 years and above. Use of Dilaminid through RNTCP for treatment of XDR and MDR TB for children between 6 and 17 is recommended. If you see this chart, it's in Group A, bedaquiline, WHO recommendation. Group B doesn't have that. Group C has Dilaminid. So now they are part of the core treatment regimen. But there has been limited availability of drugs. Indian living with XDR, MDR, TB, and the classical case of that of Shreya, who actually battled to access bedaquiline. She was able to do so only after a court intervention, but it was too late, and she died because bedaquiline was actually made available to her much, much later. So it is very important that these drugs are available. Why are they not being made available? Because two companies have patents. Janssen has patent on bedaquiline, and the government relies on donation. In 2016, Janssen only donated 600 courses of bedaquiline to the RNTCP conditional program for access. Compassionate use program was concluded at some time. Tenders were invited, but they could not obtain any fresh bedaquiline. Similarly, Dilaminid is available from Otsuka via Mylan, who are also the patent holders of Dilaminid in India. They gave about 400 courses of Dilaminid as donation. Both the courses for bedaquiline and Dilaminid are insufficient to treat MDR patients, when in fact, the National Strategic Plan in 2017-25 indicated the scaling up of diagnosis would result in 3-fold increase of MDR TB notifications and 10-fold increase in XDR TB numbers. So these are simply not sufficient. The other thing that has come about is the salvage regime, which was actually conducted. There was a study conducted by the National Institute of Tuberculosis and Respiratory Diseases for 53 patients, which reported that better results with lesser adverse events was available if bedaquiline and Dilaminid were used together. In fact, the 2020 guidelines of WHO recommend the use of bedaquiline and Dilaminid together, who have limited options. Bedaquiline is available at 138 centers and Dilaminid only in 23 centers. The numbers are in a chart which we have been able to gather in the Lawyers Collective. Number of MDR patients, RRTB patients is about 124,000. Numbers who actually administered treatment as per WHO guidelines about 55,000. Who received bedaquiline is about 10,000. Numbers who actually are eligible but not received is 44,000. Numbers who received Dilaminid is 60, and numbers started on treatment is in 2019 about 1,100. Numbers who have not received is 830. Numbers who have not received, who have received bedaquiline and Dilaminid is only 6. So there's a huge shortfall, and therefore we feel that the treatment should be according to the WHO standards. It should be oral, as has been recommended, at the safety of the rooms. Bedaquiline and Dilaminid are oral drugs, which are very important to phase out injectables. They should be made available. Dilaminid is very important for children who are 3 and above. We have only approved 6 and above. So we need to purchase these drugs. If purchase it from Janssen and Otsuka, the cost will be prohibitive. Each course of bedaquiline for 6 months is 26,000 rupees, and you need it for 6 months or even more. You need Dilaminid. Indian government bought Dilaminid. It cost them 94,000. We estimate that if they actually buy the courses from Otsuka and Jensen, it'll cost them about 150 crores. That's just a lot of money. If generic companies were sourced, then they would actually be available at 10% of the price. But both Jensen, and we don't know about Otsuka, but Jensen has certainly refused to give a voluntary license. Therefore, we have to think of other options. And the other options that I thought about are a compulsory license. But compulsory license has to be applied for by a generic company, which would actually mean an application under 84, Section 84 of the Patents Act. That is not a feasible thing at the moment. The other option is to force the government to issue an order for government use under Section 100 or a compulsory license for public non-commercial use under Section 92. Offer or invite offers from generic companies to make these drugs. In fact, that is exactly what has been done by civil society. Survivors have filed a petition in the Bombay High Court on the basis that these drugs, Delaminate and Bedaquiline, are required desperately for MDR and XDR TB patients. Both have been approved by WHO and the Apex Committee in India. Bedaquiline is actually resulting in 3 times reduction of mortality in MDR XDR TB patients. Non-availability actually creates a problem of resistance. We cannot rely on donations from Jensen and Otsuka, and patents is a big impediment. These patents would have to be suspended. If you don't suspend them, then buying them would actually cost about 150 to 160 crores. Generic companies would be 1/10 of the price. So government can exercise powers under Section 100 or 92 of the Patents Act, and all the conditions of them are satisfied. As Jensen has refused voluntary license, the condition is desperate. There is a national emergency, and also this would realize the right to health under Article 21 and the international conventions. Both these drugs are on the WHO list of essential medicines. Now we have to see what the reliefs that are sought. The reliefs in the petition are that the government issues government authorization order under Section 100 or a compulsory license under Section 92, and undertakes forecasting of the requirement of the drugs, both of them, complete a rollout oral regime by phasing out injectables, develop a timeline for procuring additional courses of Bedaquiline and Delaminate under NTEP, rollout of Bedaquiline for all the MDR patients in Maharashtra and Mumbai, also children above 6, or pre-XDR and XDR patients be provided with a combination of Bedaquiline and Delaminate and Salashib. We have to see what the court does, and I would like to offer myself for answering questions. Thank you very much.
To all of our speakers for their insightful remarks around the broader socio-economic determinants, the importance of community involvement, the policy changes which are required, and how we can build political will and legal advocacy towards our larger aim of making TB care in India more responsive to the needs of those who are most impacted by it. The panel, through their presentations, indeed have highlighted our core argument that if we want to reimagine TB care and services and revitalize discussions on India's TB epidemic, this cannot be done without addressing the socioeconomic factors and other vulnerabilities which patients and survivors have. In fact, some of these, I think, have been reinforced during the last year through the COVID-19 pandemic as well. It is important for us to recognize, generate evidence on these, including lived experiences, and indeed use this for pushing for more advocacy for a nuanced, expanded, and empathetic program. Thank you for listening in. We look forward to your questions and comments. We will now initiate our Q&A session. Thank you. Hi, thank you for joining, and I think we'll get started because we have limited time remaining in the panel. But thank you to all the panelists for your excellent points. I think this was very, very useful, and I think set the stage. We are on the day 2 of the summit, but I think this was a really important panel to sort of highlight some of the important aspects from both sort of understanding some of the socioeconomic and determinants of TB, but also reinforcing some of the experiences through your lived experiences as well as the work that you've been doing in research, advocacy, legal rights, etc. So I want to start off probably by, maybe this question I'll direct it to you, John. You spoke about the fact that you've been working in the economics domain. You also are a TB survivor. Maybe if you could briefly summarize your perspectives around, given the experience with the pandemic, what are the sort of major factors around poverty, TB, and how does it intersect also with other issues like caste, class, gender, and how can we address those in our response when we look at TB specifically?
Well, that's a very large question. I think it would take a long time to answer. But you see, I think that when it comes to TB, obviously, as several speakers have stressed, different groups and sections of the population are differently exposed and have different difficulties in getting over the disease. So I think we have to be, of course, very aware of the inequalities that make it difficult to handle TB, whether it's in the form of prevention or providing treatment. I think that's a general problem in public health in India. I mean, the inequalities are obstacles are at every step, whether it's in providing the basic facilities that protect people from disease, or whether it's in providing the public services that will help them out of it. At the same time, I don't think it would be completely right to see it only as a disease of poverty. I think it's something, the TB can ultimately hit anybody, as all of us illustrate. And so I think there also has to be an aspect of universalism in both the prevention and the treatment of TB. I think the basic approach has to be universalistic. I would say that the public health system has to provide what is required to ensure that everyone has access to free treatment and also is, to the extent possible, protected from getting the disease in the first place. And then once that framework is in place, we have to, I think, give attention to the more marginalized groups, including all the groups that we have spoken about in this panel, whether it's those who are marginalized because of poverty or because of sexual preferences or gender or caste and so on. I think definitely if we don't pay attention to those groups specifically, they are going to fall through the cracks. So just this morning here in Jharkhand, I met a TB patient, a woman who has under treatment for 8 months, and she still looks really very sick. And my impression is that the treatment is not working, and she is in a situation of sort of complete disempowerment. She doesn't have proper food. She's not educated. She doesn't know how to navigate the system. She's from a scheduled tribe, so she has all these disadvantages. And unless we pay attention to these disadvantages and treat all patients the same, I don't think we'll be able to do this study. That's all I can say in general terms. I hope this makes sense. But your question is really very large, so I think there are many other aspects that maybe some other speakers will address.
Sure. Thank you, John. No, that was very insightful. Madhvi, if I can pivot to you now. You worked for a long time in Chhattisgarh. If you can maybe from your perspective, issues from financial support and nutrition when we talk about addressing TB as a disease, and how can we sort of work on that comprehensively in the program, given what the health minister also said in his introduction. Given what the health minister also said.
Sorry, so am I audible? Because I could hear you in a very sketchy manner. I hope I am audible. Yeah.
Yes, you are.
I think you're talking about
go ahead.
nutrition access and financial support for TB patients.
That's right.
Yeah.
Yes.
So right now, when we started the advocacy work for nutrition support in TB patients, we were talking about food basket for sure. But because there was a lot of resistance that TB programs cannot get into distribution mechanism because they are already overwhelmed, in terms of other documentation and service part. So it was reduced down to some measly amount of say 500 rupees a month, and that too it is sometimes, most of the times I would say, is delivered at the end of the treatment. So what was supposed to be an enabler for nutrition support, it turned out that it was received as a lump sum amount at say 4th or 5th month of treatment. So the most important thing will be that even if this is a small amount, it should be delivered on time. The second thing that I have seen is that we don't provide enablers when it comes to when we give these 500 rupees. So most of the times, when we talk to the policymakers, there is this circular argument that if you give money, it is misused. If you give food, there is food sharing. So and on the other hand, we do talk about social support systems, SDGs, and eliminating poverty. So the argument doesn't end anywhere. So giving enablers for even best utilization of this 500 rupees, I would say, in terms of context, local geography specific advice in terms of what should be, how it should be used. The second thing is people who are in maternal and child health, they will talk about nutrition support for mothers or under 5. When people are in nutrition and TB, they're talking about patients as such. But what I feel is that when a family is, having a patient with tuberculosis, there are lots. I mean, I already talked in my presentation about various factors that lead to that. So we have to think of family as a whole, which is in a vulnerable stage in their life. And to say that we are making people dependent on that support is a very, argument which doesn't take us anywhere. So everybody wants to be independent. So if they are able to survive that vulnerable period by giving nutrition support to the family as a whole, probably we are helping the patient as well as the family. We are taking care of the argument that there is food sharing as if it's a crime, right? And once the patient is out of that vulnerable period and the family is out of that vulnerable stage where they can get infected, probably, and there are multiple things like, adolescence, late adolescence is out of any social protection network at the moment. They are going to become adults. They are vulnerable already because of undernutrition. They are the ones who are a active population working very hard, and with their distress, they're getting, from infection, they may proceed to the disease. So extending it over there. So these are the various things that I feel, we can do as far as poverty, nutrition, and TB is concerned.
Thank you so much, Madhvi. Now, Ashna, you spoke about rights-based approaches being important. If I can request everyone else to just go on mute, except if you're responding to the question. So, Ashna, you spoke about the rights-based approach to healthcare being important, but you also focused on the fact that there is a lot of exclusion of.
I'm sorry, I can't hear you. Could everyone else just go on mute, please? Everyone else just go on mute.
Yeah, John, if you can try to go on mute as well.
Thank you so much.
Yeah, great. Yeah, okay. So, Ashna, I was asking you that you spoke a lot around the fact that there is a fair bit of marginalization. There is the issue of stigma as well, and you especially used the example of minorities, specifically sexual minorities. So do you see that there is some kind of an erasure of these populations in our response, and we sort of don't recognize them formally, yet they have very stigmatizing experiences when they access healthcare? And what can we do to obviously improve on this so that the program responds to their needs?
Right. Thank you for the question. Am I audible to everybody? Am I audible, Anna?
Yes, you are. Yes, you are. Go ahead.
So to start with, the issue of it's not just specific to this policy. I'd like to say that this is emblematic, largely, as I said in my presentation, of TB care as a whole. That we are thinking about being gender responsive, but we're not there yet. And because if it seems like there isn't sort of marginalization of the trans community or an erasure of sexual minorities, it is because there is. And one of the arguments that we frequently get is, at least we're thinking in that direction of a gender responsive policy. The means justify the ends. You have a policy now, which you didn't have before. And my response to that simply is, as Steinem says, the means are the ends, which I said in my presentation. I'll give you a very simple culinary metaphor, and I'm going to switch to Hindi for this. But अगर आपको बेसन का हलवा बनाना है, तो आप सूजी से नहीं बना सकते हैं ये बोल के कि the means justify the ends, because सूजी से सूजी का हलवा ही बनेगा. When you're talking about framing a gender responsive and a gender inclusive policy, how can the framing committee, at the beginning, which is the first step, be exclusionary in its framing largely, in its constitution largely, where there was some representation by the trans community, very limited as far as I know, but to the best of my knowledge, there was nobody from the LGBTQIA++ communities, and this is a framework for them. So what are we doing here? How do we expect this to be gender responsive when none of them were in the room, when their health needs weren't accounted for? So that's one. The other thing is, all social policies tend to have this problem, which is we have sort of internalized that the welfare state is engaging in charity towards its marginalized citizens, and even they internalize it to some extent. कि नहीं सरकार हमारे लिए इतना कर रही है, and सरकार कर रही है, of course, not to take away from everything that's being done by the government, but it's very important to reframe this and to not have this paternalistic father figure of a state handing out dole, but inform this with the rights-based approach, which ensures things like participation, empowerment of citizens of marginalized communities, not as recipients of charity, but as rights-bearing citizens. And most importantly, then has clear corresponding obligations for the state and other players to uphold those rights, not just to not violate the rights. So it's not just that you have to stop yourself from discriminating against the LGBTQI community. You also have to actively ensure the realization of the right. Because as we know, there is a very critical distinction between the normative recognition of a right and its substantive realization. And in India, though we have a fantastic constitution and we have lawyers who are using legal advocacy to bring about more rights-based change, the gap comes in the substantive realization. And I think that would substantially change if you involve these communities, if the approach is not a pyramid ranked approach, but it's a circle where the affected communities are involved in decision-making, in planning, in implementation, and then at the end stage as recipients, of course. So, thank you.
Absolutely. Thank you, Archana. Very important to keep talking about inclusivity. Anand, now coming to you, you gave the excellent example of the fight to get MDR TB drugs and access for them. But overall, if we look at your own experience with doing legislative advocacy for many years now, what kind of interventions are we looking at trying to bring to the table so that we can get better, quicker access to diagnostics, to new drugs in the context of TB, and how can we work with the government for that? Anand, you're muted. If you can unmute.
Thank you very much, Anand. Well, Ashna has taken the words out of my mouth, and I wanted to actually say similar things, but let me elaborate what she said, because I worked on that issue precisely on those areas for the last 30 years. HIV was a response precisely based on rights-based approach. And the most important and crucial aspect was to empower the communities. How do you empower the communities? I'll just give you a very anecdotal example. And the persons living with HIV were told before 95 that they were facing certain death. So earlier on, we couldn't do much about treating them in any way except, sort of palliative care, as it were, and having a buddy system, which was even popularized in India. But after we got medicines, triple combination therapy, we were able to train and advocate and inculcate the rights-based approach amongst the people living with HIV, who included, by the way, vulnerable communities like sex workers, the LGBTQI community, particularly gay men and transgender persons, and also persons using drugs. So we were able to first of all inculcate the idea of a right, that it is your right. And that's why today we are not part of their leading group. They decide what they want to do on their own, and they use us as consultant lawyers. That's the major advance we were able to make within the HIV community, not only in India, but more so in India, say amongst the sex workers than any other country in the world. Why has this not happened in TB? And that's a very big question we must answer. We can't blame the government for it. And I think we need to actually take a step back and look at what is not happened here and why is the reason it's not happened. And one of the reasons is that there's a critical difference between HIV as an ailment compared to TB. TB is treatable, and after I've been a TB affected person, I can be treated and I would be a TB survivor. I may not have any interest in working on that issue. Whereas if I'm HIV positive, because there's no cure, I'm always going to be HIV positive. And before I actually really become ill, I'm really active. I can be on the table shouting, demonstrating, etc. So those are critical differences that we have found. In TB, we have now been able to, with a number of activists and survivors, there are a number of people who are now quite active in Mumbai and Delhi. And when we did Shriya's case, we were able to get in Delhi. I talked about Shriya's case where bedaquiline was actually available only after we went to court. So based on the experience we've had, we are trying to develop a layer of TB activists who actually become not objects of our exercise, but subjects of decision making. That is very critical because the paternalistic attitude in India is so strong, whether it's in politicians or NGOs, that you don't allow people to exercise their own right to self-determination, decision-making. And that is very, very, very important. We haven't seen that in TB, and that is also reflected in the government. If you see the NTEP, the program, and compare it to the NACO-led HIV program, there's a critical difference. The NACO cannot afford to ignore the community at all, or activists on that issue. In the TB program, they can afford to ignore it, and anything you do is seen as a criticism of that program. So there's a need to change the dialogue, and therefore I think the rights-based approach has to be actually utilized even in TB, and it's based on an international notion which in India we have adopted, and those critical international conventions are part of our domestic law under the Protection of Human Rights Act. Unfortunately, the courts have not really elaborated it. At least the Supreme Court has not. There has been some elaboration of that kind of thinking in the Delhi High Court judgment, where I was able to argue. I still remember Justice Ravindran asking me, what is the right to health? So we had to explain, but there has not been a clear opportunity to expand those ideas. Some of those have been incorporated in the HIV Act, okay, which incorporate the principles of non-discrimination, consent, confidentiality, access, and availability of goods, facilities, and services related to health. That's what we have to talk about. But this means that as NGOs or activists or lawyers, Jean is here, Ashna is here, Madhavi is, Anant, you are here. We have to devote our time to talk to TB survivors and tell them, look, this can be done. And we've got people on board now. We have to expand and be able to make a critical level of those people so they take the flag forward. That's the critical thing to be done now. If we want to actually realize the right to health care TB affected persons or people living with TB. So that's what I want to say. Thanks.
Thank you so much, and I think that's a very clear pathway, but also homework for all of us in building those networks and also supporting TB survivors in raising those issues. Well, unfortunately, we are completely out of time, but I do want to thank this excellent panel, John, Ashna, Anand, Madhavi. Thank you so much for joining. These were really, really important issues which were raised, and I'm glad that this was the first thing we discussed on day 2 of the summit. Please let's continue these conversations. For those who are viewing, kindly stay on for the rest of the summit. And I look forward to your follow-up comments as well online as this summit goes on. Thank you and take care. Bye for now.
Thank you very much.
Thank you.
Thank you. Thank you.
Despite the magnitude of the challenge, India has embarked on an ambitious journey to eliminate TB by 2025, which is 5 years ahead of the global targets. India's National Strategic Plan for 2017 to 2025 advocates going where the patients go. And to achieve this ambitious target, it is both essential and critical to engage the private sector. So joint effort for elimination of TB, or JEET as it is popularly called, is a large private sector health initiative ever carried out in India. It actually has created a platform to reach out to the various private sector health providers, which includes laboratories, clinics, private practitioners, and helps the private sector patients to access rapid diagnostics, quality of care treatment, and also provides treatment adherence support so that the patients are able to complete treatment. And while doing this, it also facilitates notification of TB cases. JEET is being implemented in close coordination with the National TB Elimination Program. This project is supported by Global Fund and is being implemented by a consortium consisting of Foundation for Innovative New Diagnostics, William J. Clinton Foundation, and Center for Health Research and Innovation. Primarily on private health sector facilities, the project aims to improve notifications, provide patients with quality diagnostic services, and standardized and rational treatment without the patients incurring out-of-pocket expenditure, and also helps them by providing treatment adherence support for favorable treatment outcomes. In addition, the project also facilitates providing incentives to the patients, like linking them with the Nikshay Poshan Yojana for nutritional support, and also incentives for the providers for notification. So through these interventions, the project aims to improve notifications and ensure that the patients get good quality diagnostic and treatment services and are able to complete their treatment without interruption. The project, which was started in 2018, aims to notify 1.6 million TB cases over 3 years and achieve a treatment success rate of at least 70% among these patients who get notified. So Project JEET is being implemented across 478 districts covering almost 24 states across the country. In 2019, over 4.5 lakh cases were notified by the project, and this contributed to nearly 34% of the private sector notifications across the country, which is a remarkable achievement. So JEET has also been successful in implementing several other activities, which includes mapping the healthcare facilities across these 478 districts. A lot of operational research has been done under the project to study the patient flow, the patient's health-seeking behavior, the patient's diagnostic and treatment practices, and what are the barriers and challenges for the patients to complete treatment successfully. This has been a unique project and has actually helped improve the notification of private TB patients in the country significantly. In resource-constrained countries, low-middle-income countries, similar projects can actually help in improving TB case notifications, reducing catastrophic expenditure, and also helping patients complete their treatment successfully.
Hi, my name is Devashri Lokhande and I am an ex-DRTB survivor. When I was fighting TB, I had to often encounter stigma. The stigma I faced affected my mental health. I started having negative thoughts and I felt isolated. It made me feel depressed and lonely. How did I cope? I reached out to people. I started talking to my family, especially my parents, about the stigma and its effect on my mental health. I reached out to other TB survivors for guidance. Most importantly, I stopped blaming myself for my disease. TB can happen to anyone. If you are fighting TB, please reach out to people and talk about the stigma and mental health challenges you are facing. Do not suffer in silence. For more information, download the Talking TB app. You can also write to us on our Facebook, Instagram, Twitter, or ShareChat.
Hello and welcome to our panel, A Cure Without a Sting, Understanding Stigma and TB Care in India. Stigma is often associated with TB and is regarded as a strong barrier to health-seeking behavior. It is also a cause of significant suffering for TB-affected individuals and communities. Stigma causes the fear of losing social status, marital problems, the fear of losing employment, and is also the cause of hurtful behavior by the community. Stigma also has an impact on treatment adherence and the behavior of family members towards the TB-affected individual. It also influences the TB-affected individual's relationship with themselves. This, in turn, affects the mental health of the patient and their well-being. The question before us today is no longer whether we need to actively address TB-related stigma or not. The question before us is if we can comprehensively address TB in India or elsewhere without addressing stigma at multiple levels. What do we know about stigma? How do we unpack it, learn from the lived experiences of those affected or those providing care? We also need to learn from other examples like HIV and how stigma mitigation was achieved there. Directing towards this discussion is our panel, which is led by Devashri Lokhande, herself an ex-DRTB survivor. She will be presenting case studies from her work with TB-affected individuals on how stigma has impacted them. She will be followed by Dr. Saurabh Mehrotra, a leading psychiatrist from Medanta Medicity, and he will be talking about how stigma affects TB-affected individuals, what stigma actually is, and how we can actively address it. His presentation is followed by Dr. Kishore, formerly at the Hinduja Hospital, who has had extensive experience of working with TB patients, counseling them, and helping them actively address stigma. Finally, we have Yashwant Marathe, who is himself an MDR-TB survivor and is currently working with TB-affected individuals to help them address stigma. We hope through this panel that we can come together and bring some elements that define a comprehensive stigma mitigation strategy and approach to help India, but also numerous other countries. I look forward to hearing from these panelists, and I also look forward to hearing from all of you post the presentations for a lively and engaging discussion. Thank you, and now over to the panelists.
I'm Devashri Lokhande, an ex-TB survivor and a fellow with Survivors Against TB. We're bringing to you the India TB Summit. And this session is going to talk about stigma and TB, where we are learning from patient stories about how stigma affects TB care. As a TB survivor and a fellow, over the years, we've received countless queries, countless sharing of experiences from TB patients all across the country. And throughout all these stories, there's been a basic commonality with regards to stigma that a TB patient faces. Not just the patient, their extended families, loved ones too. So this session, we're really going to study how stigma affects the TB patient care from the point of view of 3 case studies and different points which needs to be addressed with respect to planning a strategy for stigma care. Going to the first case study, we're going to talk about Tejal, a female ex-TB survivor, from the point of view of stigma, healthcare, and mental health. So she faced stigma in her community and was often subject to thoughtless remarks and questions while undergoing treatment. Neighbors boycotted her and her family, creating forced isolation. Post-surgery, the hospital staff would openly discriminate against her, moved from the first to the last ward because no nurse wanted to take care of her. She would be made to stand out in the sun at the government doc center because she had ex-TB. And lastly, spoken to rudely by the health staff, implying that it was her fault that she got TB. So some very important key takeaways from her case and which needs to be kept in mind. So the stigma came from, it was externalized stigma where it came from society. It impacted not only her but her family and led to social isolation, not an easy or not a good environment for a TB patient to be healing in. And thirdly, most importantly, she faced stigma right from healthcare workers. The very people who are supposed to be taking care of her stigmatized her, added to her burden of mental health, and it made her feel as if it was her fault when it really wasn't. So that shifting of the blame onto a patient is completely wrong and needs to be addressed. So this young girl who got TB at a young age, and she came to this very important conclusion. There is so much ignorance about this disease that it makes life impossible for the TB patient, says Tejal. I mean, so many years of planning TB care and we couldn't realize this or make a difference in the care. So the next case study which we're going to talk about is Oves, who is a TB survivor. He's a person living with HIV and he's the first Indian to receive bedaquiline. And his TB story, basically, we're going to look at it from the angle of TB, HIV, and stigma, essentially infectious disease and stigma. So he took TB medication for nearly 7 years, underwent surgery, and is taking his HIV medication even today. He's a tailor, father of 2 children and a husband. He and his wife never told the neighbors of his illness out of fear of social ostracism and discrimination, which he feared would affect not only himself, but would be directed towards his young children. When first diagnosed with TB, despite being unable to afford private sector treatment, he chose to avoid treatment at the hands of the government sector. So 2 very important points. Infectious diseases and stigma. It is a very heavy burden for a TB patient to be bearing, and for them to be not able to share their conditions even with their loved ones is very wrong, and we really need to drive the silence away from this topic. And this stigma, which was, he would fear that it would be directed towards his young children. So not only is he fighting for his life with 2 dangerous diseases, he's even worried about how his children would be treated in society. And the second point in his case, very important. So there's this inherent perception in the minds of TB patients that the treatment from the government sector would be stigmatizing to them. The treatment center would not be understanding, would not be kind, would not be empathetic. So we really need to plan out how this image can be changed, and that is what strategic planning should have taken into account. So that's his case study. The third case study, a very important case study, this is about a transgender woman. So we're going to look at her story from the point of view of TB, HIV, gender, and stigma. In a sense, infectious diseases and stigma. So her case history is that she had TB and HIV. She had no family support whatsoever on account of her gender identity, no stable income. So despite all this, she would still go to the TB government center. She would go to her ART center, but the doctors refused to touch her or look at her and would send her away. Imagine, this woman was fighting for her life, but the doctors treated her this way only on account of her gender. So this was, it's a heavy, heavy burden to bear. And this is what, it was her right to access this care, but only on account of the stigma or this mental perception in the minds of the healthcare workers. She could not access care, which was her right. So layer upon layer of gender-specific stigma, TB stigma, and HIV stigma, she was dealing with all that. The direct impact of all this was that she couldn't complete both her HIV treatment or her TB treatment. She had no familial support whatsoever on account of her gender identity. And as a direct result of her not being able to complete her treatment, she lost her life. Death seemed preferable to her rather than approaching the stigmatizing healthcare system and social construct. Merely on the basis of her gender identity was she made to bear this heavy burden. The system failed her. So in a sense, these 3 case studies, I know they're heavy to bear, and when you come to know of these stories, it really makes you angry. It makes you want to demand a change from the system. It makes you want to plan strategies. It makes you want to really, take an intervention and look into the strategy planning, look into the system and demand a change. So what we learn from these stories, in a sense, is stigma affects everyone in varying degrees. Stigma comes from the self, surrounding environment, people and health systems. So that, in a sense, is talking about externalized stigma and internalized stigma. Stigma is directly proportional to a patient's motivation to continue and complete treatment. There are countless stories of how patients are burdened with this stigma, and it affects it causes depression, it causes loneliness, it causes social isolation, and there is a strong chance that they will quit TB treatment. Gender and stigma, when in its effect on each gender, is nuanced and needs to be countered differently, and this needs to be taken into account when planning on TB care. Macroscopically, TB impacts families and communities to essentially build on a narrative and teaching society how to view TB and TB patients. This is very important. This image needs to be changed, that TB is an incurable disease, that we need to isolate the TB patients, we need to run away from them. This fear needs to be really taken care of, and this needs to be taken into account when planning care. So stigma kills, TB doesn't. Thank you for joining us for this session. Less TB stigma means less TB. Thank you.
Good afternoon. I'm Dr. Saurabh Mehrotra, and I shall be talking about stigma in tuberculosis. So the word stigma is derived from the Greek word for a mark or stain. And stigma is essentially a systematic process of devaluation that discredits an individual in the eyes of others. Within cultures, certain attributes are defined by others as discreditable and unworthy. And finally, when stigma is acted upon, then discrimination results. It has been identified as one of the important barriers in treating the TB epidemic. And it is necessary to address the stigma related to tuberculosis, to diagnose and treat millions of tuberculosis patients who are currently unidentified. About 4 million people unidentified do not come to healthcare services for fear of stigma. Even the life-saving potential of drugs cannot be realized without addressing stigma. Stigma is unyielding and it does not go away with small efforts. It's neither natural nor inevitable part of tuberculosis. It needs to be nurtured and enabled in order to exist. Now, Link and Phelan gave a framework of the stigmatizing process, and stigma results when some interrelated components converge. So to begin with, people will distinguish and label human differences. And then some dominant cultural beliefs link the labeled persons to undesirable characteristics. Then finally, these labeled persons are placed in distinct categories, and that's the differentiation, the us versus the them. And these labeled persons then experience status loss and as well as discrimination. So this is how the process of stigma unfolds. And the term stigma is usually applied when elements of labeling, stereotyping, separation from others, status loss, and discrimination co-occur. There are differences of power between the groups being stigmatized and the so-called main group. Main group is so how it essentially develops. These are sequential steps. The differences are seen as not normal. They are rhetorically linked to deviance or negative traits. And then the responsibility of tuberculosis to blame is established. The rationalization takes place, legitimization takes place, and the peril of tuberculosis is seen. And this leads to exclusion, and exclusion finally leads to curtailing of rights of the individuals, the status loss that they experience, and finally the discrimination that they go through. So almost all stigma involves the social construction of dangerousness, which in turn generates fear, and that's an essential step in the creation of stigma. So the dangerousness as far as tuberculosis is concerned is the fear of infection from people who may be affected with tuberculosis. There are drivers of stigma, there are different domains of stigma, and finally, there are consequences of stigma. So if you look at the various domains of stigma, there is social distance. This is when someone tries to start avoiding a person suffering from tuberculosis. There is traditional prejudice, where someone stereotypes people with tuberculosis, believing that they are in some way less valuable than others. So that's referred to as the traditional prejudice. Then there are exclusionary sentiments, where there is a wish to separate people with tuberculosis from everyone else or deny them their rights. There is a negative affect, which means there are emotional reactions such as anger, such as hatred towards people who may be suffering from tuberculosis. There is a treatment carryover, where people who have been affected from tuberculosis, even though in the past, they still worry about the fact that it may be known to others. So they try and hide it even after they have recovered. There is disclosure carryover, which means that people are afraid of the reactions of individuals when they come to know that, I'm suffering from tuberculosis. And finally, there is a perception of dangerousness, that in some way, individuals who are suffering from tuberculosis are dangerous as compared to others. There are various types of stigmas. We are aware of the public stigma, which is negative attitudes and beliefs and the behaviors which are held by the wider community or by the general public towards people suffering from tuberculosis. There is anticipated stigma. And anticipated stigma is the worry that one is going to be devalued if others or if one is diagnosed with tuberculosis. So the fear of devaluation comes in once one is diagnosed with tuberculosis. Then there is secondary stigma, which is experienced by caregivers, friends, family members, and even health workers who, they experience negative attitudes and rejection because of their association with the disease or because of their association with patients suffering from tuberculosis. So this is secondary stigma. There is internalized stigma, or there is self-stigma, in which the individual himself endorses the negative beliefs which are held by others and actually starts behaving according to these beliefs. And then there is enacted or experienced stigma. Now, experienced stigma is when the person experiences the whole range of behaviors which are related to stigma. And the last thing which we need to understand is the structural stigma, which is the laws, which is the policies, and which is the institutional architecture that itself may be stigmatizing. It may also be facilitating, and that is what we hope, but that is what structural stigma is all about. The consequences of stigma include reduced health-seeking behaviors. The people do not wear masks. This in turn may lead to further transmission of the disease. Stigma causes a huge amount of stress, leading to breakdown of individuals, mental health consequences. It undermines the relationship between the patients and the provider. It undermines recovery, compliance to treatment, and finally, it also leads to discrimination and consequences. In my opinion, tuberculosis can be eliminated if stigma can be taken care of. Thank you so much.
Hi, I am Dr. Gircha Kishore. I have working experience of over 5 years in field of TB, and I have got a chance to interact with patients suffering from TB from different backgrounds, locations, and residence patterns. So today we are going to talk about the problem that we face in healthcare system related to the stigma that is associated with TB. So it's not just only the patients and their relatives or society which is discriminating, it's also the healthcare system that we are part of contributes to it. So to understand this, we will take an example of a patient who was suffering from XXDR TB, and her case starts, she fell ill, and then she chose to access healthcare in private sector, and she went to a doctor who diagnosed her with TB and started her treatment, but she was not getting better with the treatment. So she went to see other doctors, and many of those doctors refused to see her just because she was a TB patient. And they were scared to actually see her and get infected. So she was spending money like anything. She was wasting time. She was losing her health. And so she finally decided to move to public sector for her treatment. And there too, another set of stigma related challenge came in. So at the government setting, she was basically treated like untouchable, and she was shooed away. She was made to stand outside the healthcare facilities for a long time. Also, she was blamed for having XXDR TB, which is not ideal thing to do. She was suffering, and we should show empathy rather than just being callous about it. And even nurses were refusing to even go near her, and while she was admitted. So to move on with this case example, let's see how the The problem here is the lack of knowledge, how TB spreads, and when the patient becomes non-infectious, most people, even in healthcare settings, don't know about it. And then there is a tradition of blaming. Instead of empathizing and understanding the difficulty that patients have to face, healthcare staffs are traditionally trained to dehumanize and blame the patients instead of understanding their side, their perspective too. And then there is a challenge related to understanding of poor socioeconomic conditions and vulnerable communities, which have to face the brunt of TB more than the well-to-do part of the society. Like women, they are already traditionally discriminated, and with TB, they are often have to live by their own. Their families leave them. Then trans people, they are discriminated not just by the way they have been born or they have been living, but also the system doesn't recognize that till now. They don't recognize in most part of the country that they are the third gender. And then poor people, they are suffering. They are suffering from their day-to-day activity, and then TB itself is like a chaos which comes in their life, and then people actually fail to understand that seeking treatment on a rate that is acceptable to poor people is something we should do, from not just being a doctor but being a human. So we keep on discriminating and stigmatizing those patients, and then we focus on the patient failure and not actually supporting them. So whenever a patient fails on a treatment or fails to take a medicine, we instead of trying to understand the problem, we just put the onus on the patient that they have been casual or they have been ignorant, and this is not the right way. And then there is a dire need in the healthcare workers for skill training, soft skill, empathizing. All those type of things should be inculcated in their training, and this would make the health system better for the TB patients and make this the end TB approach possible. So how do we address this? So we have to address this stigma through knowledge. We have to give proper training to healthcare staff, give them a proper knowledge about how the infection spreads when the patient gets infectious, what are the preventive measures, how the setup of the healthcare institution should be to have the minimum risk of infection, proper ventilation, and just creating a barrier or negative pressure can help a lot. So this knowledge should be imparted in our, not just in the healthcare staff's mind, but also in our system, in our institutions. Then stigma can be addressed through skill building. We have to, like I told multiple times earlier too, we have to learn to empathize with patients. And this has to be trained. The healthcare staff has to be trained regarding this. And they have to be soft-spoken to those patients. They should connect to those patients. Then only they can actually tell their problem. Otherwise, they are just living in their own world and we are not able to know their problems. Again, stigma through creating comprehensive patient support. Like I talked earlier, we have to give proper support to those patients. We have to give them instruction, know their problems, give them the solutions that can help. Give them instruction, specific instruction, when to complain, when not to complain, how to live in their homes. Like simple example, you have to keep windows open, keep proper ventilation, use of mask. And if there are kids around you, you have to be cautious and take preventive measures rather than just spreading infection. We have to understand their side too. They are often living under this fear that they might infect the other people in their family or their community. So coming to positive reinforcements, human right and system approach can actually help solving some identifying and solving some stigma related issues. We have to segregate the data related to the vulnerable community to identify what are their challenges, what are the problems they are facing, and specifically act and work on it. If there is some complaint, we have to act swiftly. Then only the trust is built. And then to impart knowledge to the society. The preventive measures are more important than any other thing. In preventing and ending TB, we have to spread the knowledge about TB. We have to spread knowledge how it can be prevented, how it can be treated, where it can be treated, and who, if all the guidelines related to it, they should be aware of. The helpline, they should be aware of. And in this, since we are living in a digital world now, we have to create a social network strategy that can help addressing these issues. So thank you. I hope this helps and it saves some patients.
Hello, my name is Yashwant Amrut Marathe and I'm happy to be speaking at India TB Summit. जब मैं 18 साल का था तब पहली बार मुझे टीबी डिटेक्ट हुआ तो मेरे फैमिली डॉक्टर ने मुझे चेस्ट स्पेशलिस्ट के पास भेजा। वहाँ पे हमने 2 बार टेस्ट करा है, जिसमें एक टेस्ट में डीएस-टीबी आया, एक टेस्ट में एमडीआर टीबी से हुआ है ऐसे डिटेक्ट। और डॉक्टर ने मुझे डीएस-टीबी का ट्रीटमेंट शुरू करवा दिया और लगभग ट्रीटमेंट के 4 महीने बाद जो कल्चर रिपोर्ट करा उसमें मुझे एमडीआर टीबी डिटेक्ट हुआ। इसलिए मुझे मेरे चेस्ट स्पेशलिस्ट ने बीएम सरकारी अस्पताल में भेज दिया। वहां से फिर से मैंने अपना चेकअप करवा के मेरा ट्रीटमेंट जो है शुरू करवा लिया। ट्रीटमेंट के शुरुआत के दौर में मुझे बहुत सारी तकलीफें होती थी, जैसे जॉइंट पेन होना, आंखों की समस्या होना, कान से कम सुन, थायराइड वगैरह, और बहुत सारे अलग मेंटल हेल्थ इश्यूज से भी मुझे गुजरना पड़ा था। लगभग ट्रीटमेंट के 1 साल बाद मुझे बहुत सारी मेंटल इश्यूज से गुजरना पड़ा, जैसे कि मुझे अपने खुद के बारे में या फैमिली के बारे में बुरे ख्याल आना, मेरे करियर के बारे में, और इन सारी चीजों के कैसे हैंडल करना, इसका मुझे सही से प्रॉपर एजुकेशन नहीं था। इसलिए मैंने आपको सेल्फ हार्म चूज किया, सेल्फ स्टिग्मेटाइजिंग करने लगा। और लगभग मैंने साइकियाट्रिस्ट के ट्रीटमेंट के बावजूद भी मुझमें काफी मेंटल हेल्थ में मेरी सुधारणा नहीं दिख रही थी। इसलिए मैंने ब्रह्म कुमारी में जाकर राजयोगा मेडिटेशन सीखा, उससे मुझमें पॉजिटिव एटीट्यूड डेवलप हुआ। उसी के चलते मैंने अपना इलाज तो सही से पूरा किया ही, पर इलाज खत्म होने से पहले मेरी 2nd ईयर बीकॉम की और साथ ही में प्रोफेशनल अकाउंटिंग की पढ़ाई भी पूरी कर ली। ट्रीटमेंट के दौरान हमें दवाई लेने के लिए बीएमसी के हेल्प पोस्ट में जाना होता था, तो वहाँ का स्टाफ मेंबर हमसे ठीक से बर्ताव नहीं करता था। जब भी हम एंटर करते थे हमें देख के वो अपना मुंह ढक लेते थे, हमसे दूरी बनाए रखते थे। कई बार हमसे ऊंची आवाज में बात देखिल की जाती थी। इन सब से हमको एक ऐसा गिल्ट फील होने लगा, हमने कोई क्राइम किया है। सिमिलर थिंग जब हम हॉस्पिटल्स में जाते थे चेकअप के लिए, तो वहाँ के डॉक्टर्स भी हमको बैठने के लिए सीट ऑफर नहीं किया करते, हमसे दूरी बनाए रखते थे, और हमारे जो भी क्वेश्चन थे उनका आंसर ठीक से नहीं किया जा सकता था, नहीं करते थे। विदिन 10 to 20 सेकेंड्स हमें प्रिस्क्रिप्शन लिख के हमें भेज दिया करते थे। इन सारी चीजों की वजह से मुझे काफी मानसिक तनाव झेलना पड़ा, और मैं खुद को सेल्फ स्टिग्मेटाइज करने लगा कि मैंने कोई तो पाप किया है, कुछ मेरा में एक गिल्ट फील होने लगी। बट इस सारी चीजों में एक अच्छी बात ये रही कि मेरे फैमिली और फ्रेंड्स ने मुझे बहुत ज्यादा सपोर्ट किया। मेरे फैमिलीज में मुझे कोई चीज की कमी नहीं होने लगी। मेरे ट्रीटमेंट के दौरान दवाइयों के अलावा जो खाने पीने में न्यूट्रिशन के लिए जो भी चीजें चाहिए, साथ ही में मेरे कॉलेज की पढ़ाई के लिए जो भी मटेरियल चाहिए वो सब मुझे अवेलेबल कराया। मेरे फ्रेंड्स में जब भी मैं उनके साथ होता था तब एक मेरे आस पड़ोस में एक चेयरफुल एनवायरनमेंट क्रिएट करके रखते थे। इन सारी चीजों की वजह से मेरा ट्रीटमेंट जर्नी एक थोड़ा सा लाइट रहा और मैंने सक्सेसफुली अपना ट्रीटमेंट कंप्लीट कर लिया। करंटली मैं बीएमसी के साथ जुड़कर पेशेंट काउंसलिंग करता हूँ, जो एमडीआर पेशेंट इंटरप्ट है उनकी काउंसलिंग करता हूँ। साथ ही में सर्वाइवर्स अगेंस्ट टीबी ऑर्गेनाइजेशन के साथ जुड़ के पेशेंट एडवोकेसी करता हूँ, पेशेंट और उनके फैमिलीज की काउंसलिंग करता हूँ। ट्रीटमेंट के दौरान पेशेंट की मानसिक स्थिति जो होती है, उनके फैमिली पे क्या गुजरती है, उन सारी चीजों में भली भांति वाकिफ हूँ। इसीलिए मैं अपना एक्सपीरियंस दूसरे पेशेंट और उनके फैमिली के साथ शेयर करके उनका मनोबल बढ़ाता हूँ और उनको ट्रीटमेंट पूरी तरह से कंप्लीट करने में उनकी मदद करता हूँ। स्टिग्मा को हम पेशेंट एजुकेशन से भी दूर कर सकते हैं, जैसे कि पेशेंट को उनके इलाज के बारे में पूरी जानकारी देना, उनको क्या चीजें करनी चाहिए, क्या चीजें नहीं करनी चाहिए। साथ ही में पेशेंट के साथ माइंड में जो भी डाउट्स होते हैं, मिसकंसेप्शन होते हैं टीबी को लेके, अगर उनका सही से उनको जवाब दिया जाए, उनके अधिकारों के बारे में अगर पेशेंट को बता दिया जाए, तो पर्सनल लेवल पे स्टिग्मा को एनकाउंटर करने में पेशेंट को बहुत ज्यादा मदद होती है। सेकेंडली, स्टिग्मा को हम कम्युनिटी अवेयरनेस से भी दूर किया जा सकता है। कम्युनिटीज को अवेयर किया जाए स्टिग्मा के बारे में, टीबी से रिलेटेड कम्युनिटीज को जानकारी दिया जाए, सेमिनार्स और वर्कशॉप कंडक्ट करके, एक अवेयरनेस कैंपेन्स कंडक्ट करके समाज को बता दिया जाए टीबी के बारे में। साथ ही में स्टिग्मा और उनसे होने वाली पेशेंट को परेशानियों के बारे में अगर कम्युनिटीज को बता दिया जाए, तो कम्युनिटी लेवल पे स्टिग्मा एनकाउंटर होने में मदद होगी। 13, ट्रीटमेंट के दौरान पेशेंट को फैमिली सपोर्ट बहुत ज्यादा जरूरी होता है। तो अगर पेशेंट की फैमिली को एजुकेट किया जाए, इस बात बता दिया जाए कि पेशेंट के साथ कैसे बर्ताव करना चाहिए, पेशेंट की नीड्स को अंडरस्टैंड करना चाहिए और उनको पूरा सपोर्ट करना चाहिए, उनके आस सबोताल में चेयरफुल एनवायरनमेंट बना दिया जाए, तो इन सारी चीजों के वजह से फैमिली सपोर्ट की वजह से भी आप स्टिग्मा को काउंटर कर सकते हैं। कई बार हमने देखा है हमारी इंडियन सोसाइटी में कि जब एक लड़की अपने ससुराल चली जाती है शादी करने के बाद, तो वहां पे उसको अगर टीबी हो जाए तो उनको काफी दिक्कत का सामना करना पड़ता है, ससुराल वाले उसको फिर से मायके भेज देते। तो इन सारे केसेस में अगर हम फैमिली उसको ठीक से एजुकेट किया जाए, तो फैमिली को सपोर्ट करने को आ जाए, तो स्टिग्मा को पर्सनल लेवल पे एनकाउंटर कर सकते हैं। तो स्टिग्मा को सही ढंग से एड्रेस ना किया जाए, जो भी पेशेंट है जो अच्छी केयर के पीक में है, जो उनको अपना इलाज करवाना है, वो अक्सर अपना इलाज करवाते नहीं है। जो पेशेंट ऑन ट्रीटमेंट है वो अपना इलाज बीच में छोड़ देते, और जो पेशेंट अभी डायग्नोज हुए उनको सिम्टम्स है अपना इलाज शुरू नहीं करवाते, क्योंकि उनके मन में यही डर बैठा होता है आज जो ट्रीटमेंट ऑन ट्रीटमेंट है उनके साथ जो सोसाइटी बिहेव करे, हार्श बिहेव करे, वैसा बिहेवियर हमारे साथ भी कल जाकर होगा, इसलिए पेशेंट्स अपना इलाज करवाते ही नहीं है। इसका नतीजा ये होता है कि ज्यादा से ज्यादा टीबी इन्फेक्शन का खतरा बढ़ता है और जो भी केसेस है टीबी के वो बढ़ जाते हैं। कई बार इन स्टिग्मा के वजह से पेशेंट के मेंटल हेल्थ पे, दैट आई अर्लियर मेंशन, मेंटल हेल्थ पे भी बहुत ज्यादा इफेक्ट होने लगता है, और ट्रीटमेंट के दौरान ही नहीं, ट्रीटमेंट के बाद भी ये मेंटल हेल्थ इफेक्ट चलते रहता है। इस कई बार पेशेंट को स्कूल, कॉलेज, यहाँ तक कि वर्क प्लेस में भी डिस्क्रिमिनेशन, भेदभाव का सामना करना पड़ता है। तो स्टिग्मा को एड्रेस स्टिग्मा के ऊपर फैमिली सपोर्ट द्वारा, पर्सनल पेशेंट को एजुकेट करके और कम्युनिटी अवेयरनेस से स्टिग्मा के ऊपर अगर सेशन कंडक्ट दिए जाए, तो स्टिग्मा को पर्सनल लेवल पे काउंटर करने में बहुत ज्यादा मदद होगी। आज भी हमारे हेल्थ केयर सिस्टम में टीबी हेल्थ के बहुत सारे गैप्स है, बहुत सारे फ्लॉज है, जैसे कि आज टीबी यूनिट से जुड़े हर एक स्टाफ मेंबर को सेंसिटिविटी ट्रेनिंग देनी चाहिए कि पेशेंट के साथ कैसे बर्ताव किया जाए, उनके फैमिली से कैसे बात की जाए, पेशेंट के जो भी सवाल है, मिथ डाउट्स है, उनको कैसे दूर किया, इन सारी चीजों से रिलेटेड ट्रेनिंग देनी चाहिए स्टाफ मेंबर्स को। कम्युनिटी अवेयरनेस पे ज्यादा गवर्नमेंट को फोकस करना चाहिए। फॉर एग्जाम्पल मास मीडिया में उसका प्रमोशन करना चाहिए, वर्कशॉप और सेमिनार कंडक्ट करके स्कूल, कॉलेजेस, यहाँ तक कि जो भी नॉर्मल कम्युनिटीज है, महिला बचत गट, इन सबको लेके कम्युनिटी अवेयरनेस करनी चाहिए। हर एक पेशेंट की रेगुलर इंटरवल्स पे 1-to-1 काउंसलिंग होनी चाहिए, जिसमें पेशेंट को पर्सनल लेवल पे और सोशल लेवल पे जो स्टिग्मा है उसको कैसे काउंटर किया जा सकता है, उसके बारे में पेशेंट को एजुकेट किया जा सकता है। अगर ये सारी चीजें, जो भी सिस्टम के फ्लॉज है, वक्त रहते इनको सुधार दिया जाए, तो जो भी हमारा गोल है 2025 तक टीबी को देश से एलिमिनेट करने का, वो वक्त रहते हम उसको अचीव कर लेंगे। Thank you so much for giving me an opportunity to speak at India TB Summit.
Thank you for joining us for this insightful and critical session I think this session presented some very important insights, both into addressing and understanding stigma, TB-related stigma in India. I just want to touch upon a few. I really want to thank Devashri Lokhande for bringing up the case study of stigma with a trans individual. I think sometimes the system is gender blind and seems to forget that the LGBTQI plus community needs to be included in their efforts to address stigma. I want to thank both the doctors, Dr. Mehrotra and Dr. Dalal, for both helping us understand how stigma works and what it really is, but also how it works at the health system level. This is something that you don't hear very often, and this is really critical in our fight against stigma. Finally, I want to thank Yashwant for showing us how the lived experiences of individuals can help others address stigma through patient support. I think this is a really critical weapon in our fight against TB-related stigma. So before I conclude and we move to the Q&A session, I do want to make one or two other points. I think stigma has to be understood more holistically, as the panel has clearly highlighted. There is a need to replicate examples from other disease areas, but also to learn from global experiences. There is also a need to understand the long-term impact of stigma, not just during treatment, but post-treatment and post-cure on the quality of life of the individual and their mental health. I think that is what a complete recovery should look like. So I look forward to your questions and your comments in the Q&A section. Thank you. Hello, everyone. My name is Chapal Mehra, and I'm the chair for the show. And I'm really grateful to all the three panelists who've joined us today in the middle of a work day to discuss the presentations that they were making. At the outset, let me just say that if we have been given very little time, so I will try and pose brief questions to all of you. We are also expecting some live questions, so hopefully we will be able to take up some of those. Finally, I will try and I would request you to keep your answers brief and to the point, and I will also keep my questions as concise as possible. So a very interesting panel. I think we got a lot of diverse perspectives. Two survivors on the panel. I'm most grateful that they are here. And this summit is really all about survivors and led by them. So we need more and more leaders like you. But let me first start with you, Dr. Mehrotra. We keep talking about stigma in TB, but we don't really have a stigma mitigation strategy. And stigma is one of those things that has only recently come into focus. Why do you think we do not have a stigma mitigation strategy for TB in India? And what can be done about it? If you could tell us briefly.
Yes, sure. So we've been as a country in a situation where we struggled to, recruit people into treatment. We haven't had the infrastructure of treating disorders like tuberculosis. The stigma has always been there. The stigma is not something which, it's been there for ages or decades. So the focus of treatment has always been very medical, focusing on early detection of patients with tuberculosis, focusing on treatment, focusing on how we engage people in treatment, how to prevent dropouts. So there has been significant progress in all of that. And now, over a period of time, when we are hitting roadblocks and when we are hitting barriers, we realize that stigma is one very important issue which has not been addressed till now. So people are, so to say, waking up to the fact that stigma has serious consequences in the overall goals that we want to achieve as far as tuberculosis is concerned. Stigma is present in all possible disorders. It's been there in HIV. We've seen it with corona. So stigma is not something new. In fact, I would want to say that from the time that a child grows up, we are somehow hardwired for discrimination in some or the other manner. And this hardwiring tends to become a habit. And whatever becomes a habit is very, very spontaneous. It just then happens on its own. So we need to look at, from my perspective, we need to look at two important things. We need to look at the thought processes of individuals who stigmatize. We need to look at the emotional reactions of people when they see people with hatred, with fear, with anger. And we need to look at the behavioral responses when they actually discriminate, neglect. So these are generally the responses. Yashwant talked a good deal about, the awareness raising and a lot of strategies for stigma. So we need both an awareness raising as well as a consciousness raising as far as individuals are, as far as everybody is concerned. And this is a combined effort of doctors, scientists, people affected with tuberculosis, survivors of tuberculosis, advocacy group, and policymakers. I personally feel that people affected with tuberculosis have to be included in each and every forum which talks about tuberculosis, and they can actually take the lead in a lot of these efforts. Finally, I would like to say that because stigma and discrimination is hardwired into our brain, we need to have two simultaneous process. One process, I think, is something which is specific to diseases, and we are dealing with stigma in mental health, tuberculosis, all sorts of disorders. And the other process is something which is independent, which begins very early on in schools. It's like, if there is a tree which is giving a poisonous fruit, there's no point cutting the branches. You have to look at the root. So from very early on in school, we need to talk about empathy. We need to talk about compassion. We need to talk about oneness of individuals. It cannot be an us and them society. We are all one. We are all interrelated. What one person does has an impact on the other person. So whether we talk about the life skills which need to be important, which need to be imparted from a very earlier on stage in life, or whether we talk about the concept of universal ethics, where everybody behaves and responds in a certain manner. So this process is an ongoing process, would reap us benefits maybe in a decade or two, but that's something which we need to do. I've been seeing stigma in mental health and the strategies to remove stigma in mental health for the past 20, 30 years. We have made progress, but in some parameters we've gone down despite, all the measures. So we need to look at stigma, something which is very complex. We need to look at the disorders, and we need to look at the mechanisms, and we need to cut the root, so to say.
Thank you for this very, very comprehensive answer, because I think it highlights so many issues that we often do not understand. Now, Devashri, you brought up the story of women and who struggle with TB. In many ways, the program is gender blind. TB care is gender blind because they don't see a difference between a rich person and a poor person. They don't see a difference between a man and woman. They don't see a person between a trans person. They don't see a person living in a big city to a small city. These are all important. Now, I want to ask you, what is the difference according to you in the lived experience, very briefly, again, about a man encountering TB and a woman encountering TB, or a man or a trans person encountering TB, according to you? Because you looked at these case studies, you've interacted with these people.
What I feel is that as a woman, when I'm going to even seek care, right at that step, there is a silence where I'm told to hide this thing. So there is, at that step, what I feel the intervention which would be required would be awareness, or to be not silenced, or to not stigmatize. So putting that burden on the woman patient for even seeking care, that is the first step. The second is when she's taking treatment, or when I am taking treatment and I am told that, sit away or isolate yourself, or don't talk to us, or, don't come in public spaces. So that is where discrimination, and that is something which is quite heavily gender specific, I'll tell you, because that is where when our families or our parents or caregivers they too are stigmatized, or they are made to feel that we are a burden, which probably doesn't happen so much when it comes to male patients or when it comes to transgender patients. So that for them, the journey is even more difficult. There is far more burden with respect to even seeking care, or like I said, when they go to healthcare centers or when they go travel to these places. So all these layers of burden will obviously going to stop them, or they are like hurdles which they have to do. They have to take up the fight on their own. So if we could support them, or if there are stories about all these people who, if there are positive stories which are highlighted in the media, the way it was done for COVID, where people who, they were got support and there were programs which were supporting them, and then those positive stories were highlighted. That is a start where you are raising awareness that TB is curable, even for people from different genders. They can defeat it, and how they were supported by the healthcare system at each step, and that is how the success story builds. And that is slowly how you are changing this perception that, if a transgender person or a different gender person gets TB, they're not going to be able to survive it. So changing that perception is so important, and putting the whole burden of taking up that fight on the patient is so wrong. So that is where they need the support from the system. So not just from the policymakers or from the doctors, but sensitization at each step by means of a policy is what is required, is what I feel.
No, thanks so much. Thanks for sharing your experience. Yashwant, I want to turn to you because you are still working very actively in helping TB patients. Now, most people help TB patients informally, but you are counseling them regularly.
Yeah.
And you spoke very passionately about the need at the health system level, because you didn't face stigma from your family. In fact, your family and friends went out of the way to help you control the stigma, whereas the health system was actively giving you stigma in a way, right? It was making life difficult for you. You were feeling bad about actually seeking care in the health system because that was not making you feel good. But your family, your friends, your community was making you feel very good. Now, tell me, what do you think can be done at the health system level? You touched on some of that, but you are currently working with patients who are on treatment, MDR TB patients, some of them XDR TB patients, and the side effects are horrible, mental health and physical. So there, what do you think can be done? Because I think we all understand that stigma is important, but कर क्या सकते हैं उसके बारे में, that is very critical.
So first thing, as I mentioned in my story, के सेंसिटिविटी ट्रेनिंग देना स्टाफ मेंबर्स को बहुत ज्यादा जरूरी है, क्योंकि उनके भी अपने पर्सनल मुद्दे हैं, जैसे कि वो फैमिली में, सोसाइटी में रहते हुए, तो उनको भी एक स्ट्रेस है, तो वो स्ट्रेस कहीं ना कहीं उनके काम पे भी दिखाई देने लगता है। उसी बीच वो पेशेंट को कुछ कहते, ऊंची आवाज में बात कर देते, तो सेंसिटिविटी ट्रेनिंग देना बहुत जरूरी है। स्ट्रेस मैनेजमेंट की ट्रेनिंग देना भी स्टाफ मेंबर्स को बहुत जरूरी है, क्योंकि ताकि वो पेशेंट्स के कंसर्न्स को समझे, उनको समझे कि आज पेशेंट दवाई ले रहा है, इसीलिए उसके बिहेवियर में आज कई बार पेशेंट भी वायलेंटली बिहेव करते हैं, पर उसी बीच अगर हम भी उनके साथ सेम वायलेंटली बिहेव करें तो वो मुद्दा ज्यादा बढ़ जाता है। इसी वजह सेंसिटिविटी ट्रेनिंग से हम उनको इमोशंस को समझना बहुत ज्यादा जरूरी है। साथ ही में मैं थोड़ा स्पिरिचुअल मेरे एक्सपीरियंस से कहना चाहूंगा कि पेशेंट को जब भी होता है ना सर, डिप्रेस होता है, तो उसको एक अच्छे पॉजिटिव वाइब्स की जरूरत होती है। तो दवाई तो हम दे ही रहे, साथ में एक ऐसा एनवायरनमेंट क्रिएट करना चाहिए, उसके बारे में गवर्नमेंट को सोचना चाहिए, उसके बारे में क्या किया जाए, कैसे चेयरफुल एनवायरनमेंट किया जाए हेल्थ सिस्टम में भी, और उनके फैमिली को काउंसिल करके उनके पेशेंट के सबोताल में तो क्रिएट करना है, पर हेल्थ सिस्टम में कैसे किया जाए, क्या हमको कोई ट्रेनिंग, क्या मेडिटेशन की जरूरत है ताकि हम पीसफुली पेशेंट के साथ बात कर सकते। तो इन सारी चीजों की वजह से पेशेंट को स्टिग्मा काउंटर होने में मदद हुई। और आज मैं काम कर रहा हूँ एमडीआर टीबी के पेशेंट के साथ में, मैंने आज 70 से भी ज्यादा एमडीआर इंटरप्टेड पेशेंट से बात की, जिनमें आज 45 तक एमडीआर पेशेंट्स रिट्राइव हो चुके, मेरी काउंसलिंग के वजह फिर से ट्रीटमेंट ले रहे। तो मैंने एक चीज महसूस की कि पेशेंट को बहुत ज्यादा अच्छा लगता है, क्योंकि हमने आज दवाई ली है, हम उनके इमोशन के साथ जुड़ते हैं, उनके इमोशंस को बहुत अच्छे से समझते हैं, साथ ही में उनको हमसे वो वाइब्स मिलते हैं, हम सहानुभूति कहते हैं ना, हम उनको वाइब्स मिलते हैं, उसी से ज्यादा पेशेंट अंडरस्टैंड। पेशेंट आज हमें फोन करके सर आप आपसे कॉल करके आपसे बात करके हमें बहुत अच्छा फील होता है, सर आप ही हमसे बात किया करो, हमसे इन्होंने ये, तो हम उनको समझाते कि आपकी हेल्थ खुद के लिए इम्पोर्टेंट है। अगर आपको स्टिग्मा फेस करना पड़ता तो हम उनकी उसके ऊपर काउंसलिंग करते, उनके फैमिली से भी बात करते। तो जो वाइब्स है उसी से मिल है, तो पॉजिटिव एनवायरनमेंट बहुत क्रिएट करना जरूरी है ताकि हम स्टिग्मा को काउंटर कर सके।
नहीं, थैंक यू सर, थैंक यू सो मच यशवंत, बिकॉज आपने बहुत ही अच्छी तरह समझाया, एंड आई थिंक दिस एड्स टू व्हाट सौरभ वाज आल्सो सेइंग अर्लियर. It also reminds me of the early days when we were doing counseling for LGBTQI plus individuals. One of the things was that they were not uncomfortable with who they were. They were willing to continue with their lives, but what they really wanted to hear was a reassuring voice कि दूसरी तरफ कोई उनके जैसा इंसान हो जो उनकी बात समझ रहा है. क्योंकि in the process of stigma what happens is that you are so at odds with the world, आप दुनिया से इतने अलग थलग हो जाते हैं that वापस जुड़ना एक दूसरे एक कड़ी की जरूरत होती है. You have to have a link. Sort of a question that has come up for you very specifically, and I will ask you because both Devishri and Yashwant live in big cities. How do we counter TB-related stigma in populations that do not reside in urban metropolitan spaces, or people, or those with HIV? You know, because that is a very important issue, because we are talking of a lot of experiences of stigma which are in big cities, but sometimes the stigma in small cities and small localities is very, very severe. What do you think, Saurabh? Uske bare mein kya karna chahiye?
So Chapel, a lot of it has to do with what I would refer to as health literacy. Health literacy is very, very poor in our country, both in the metropolitan cities and of course in the smaller cities or in the rural setups. So this lack of literacy now in the context of tuberculosis, the fear of an individual being infectious, our superstitious beliefs which always get mingled with the disease process, all of it leads to a state of fear in the minds of people around an individual who's affected with tuberculosis. And in a lot of these setups, this fear ultimately becomes the driving force for the discrimination as well as for the stigma. So imparting the right education, increasing the health literacy, awareness as far as people are concerned in all of these setups is one simple strategy of trying to mitigate stigma. And it has to come from everybody across the table. You have to involve the panchayats, you have to involve the local community leaders, the spiritual or religious leaders. It has to come from the policy makers, it has to come from the doctor setting in the primary health center, and there has to be an acceptance of people with tuberculosis in the mainstream society as people who are not infectious, people whom we can comfortably interact with. And their rights also have to be mentioned and taken care of. So a combination of all of these strategies should help in reducing the stigma which we see.
No, thank you. That's very useful, because I think you've suddenly expanded the scope of how stigma must be addressed at all levels. हर लेवल पे ये बात करने की जरूरत है, हर लेवल पे इसके बारे में बातचीत करने की जरूरत है. I have the last 3 minutes left, but I'm going to ask 2 more questions. First one is for you, Devishri, because this is important. An MDR TB survivor is asked this. What is the impact of stigma on life after cure? You obviously cure ho chuke hain. I still struggle being able to talk about my disease and feel guilty about it. Very briefly, if you can touch about on this, because I think this is a genuine patient who has recovered.
I feel this is a result of when the patient was not given empowerment during their struggle, and it is a burden of stigma which they weren't able to speak out of the silence, and they really want to, is what we can sense. And I mean, it happened to me also partially, and there comes a point where there is an experience which the patient faces, or after you have survived it and you want to let go of that burden. So life after TB, there are going to be people who are always going to bring that experience back to you, that, oh no, you had this, and wow, how did you do this, or it's such a difficult experience. But it comes up to me where once I start talking about my disease, about my experience, and about how, or raising questions about why there has to be a silence, or why there has to be a stigma, or why do I have to make that fight all alone. So once I start asking those questions and I start seeking similar people with similar experiences, or reaching out to other survivors, and it is a feeling of empowerment when you hear other stories and you feel that you can also share your story. And slowly, there are patients who reach out to you. You yourself feel that you can guide these people, and when you see success in those experiences, you really feel that, okay, that struggle which you went through, it was worth it, because today you're being able to reach out to so many people who you have never met, hundreds of people who live in different countries, and they just heard your story because you chose to break out of that shell that was there. And that shell was not your fault, but it was because of the stigma in the society and everything. But once you make that choice to break out of it, I think you really feel that the struggle was worth it.
No, thank you so much for saying that. And I just want to add to that, saying the disease is not you, and it's not a burden you should have to carry. Diseases happen to everybody, and TB is the way society is currently structured. Unfortunately, survivors who fight so bravely are forced to carry this burden. I have the last 2 minutes left, but I'm going to ask this critical question because I think this is very important. We've had a good discussion, but I think each of you, if you could respond in 30 seconds and tell me what are the three things that you want to see in a stigma mitigation strategy, or a stigma strategy. I'm not even going to say mitigation, in the entire health system and outside the health system, because the truth is stigma just doesn't come from within the health system, right? The health system is only the patient and the provider and health worker, but there is stigma, social stigma surrounding us. So that is very critical to address also. So Yashwant, let me start with you. आप क्या देखना चाहते हैं? तीन चीजें जो आप चाहते हैं कि एक स्टिग्मा स्ट्रेटजी में जो हिंदुस्तान कल बनाए या दुनिया में कहीं भी हो, तीन चीजें जो आप देखना चाहते हैं.
फर्स्ट थिंग मैं इन्हें कहना, जो भी ट्रेनिंग की मांग की, सेंसिटिविटी ट्रेनिंग होनी चाहिए. जो भी हम सिस्टम में इम्प्लीमेंटेशन कर रहे हैं उसमें रेगुलर इंटरवल्स पे होना चाहिए. ऐसे नहीं कि साल में एक ही बार आपने प्रोग्राम कहीं पे कंडक्ट किया, अवेयरनेस प्रोग्राम कंडक्ट किया. रिपीटेड इंटरवल से होना चाहिए. साथ ही में उसका इवेल्युएशन भी होना चाहिए किस हद तक, और ऐसे कुछ पैशनेट लोग जिन्होंने ग्रास रूट ग्राउंड पे काम किया है टीबी के, उनको थोड़ा आगे बढ़ाया जाए और उनको कहा जाए कि आप मुद्दे को हैंडल करे. जिन्होंने एक्चुअल में ग्राउंड पे काम किया है उनको थोड़ा आगे बढ़ा दिया तो और भी बेटर, क्योंकि उन्होंने एक्चुअल में काम किया है और जो भी ट्रीटमेंट लिया है तो और ज्यादा बेटर तरीके से समझ सकते हैं.
Thank you so much, Yashwant. Saurabh, briefly, if you can say three key elements that you want to see.
So, participatory approach. Anything and everything that I do, I would want to engage people with tuberculosis in the journey. Now, we have people with alcohol dependence who come to us, and a patient asks me, Doctor Saab, aap to peete nahi, aapko kya pata? And when he goes to Alcoholics Anonymous and when he meets somebody who was alcohol dependent and has quit, he's able to relate better. So I would want to keep people with tuberculosis, with TB survivors in every program that I do. I would like a lot of training of every health professional, right from doctors to anybody who has something to do with tuberculosis, in catering to the psychological aspects of individuals as well. If we can cater to the psychological aspects, then we would have better compliance, we would have people who are less stressed, and we would have less stigma. And I lead a lot of awareness raising and consciousness raising at the level of the policymakers. This should be freely talked about in every forum.
Thank you, Saurabh, so much. Devishri, we're in the last 30 seconds, but I'm going to tell you, you lead the way, and then we will close it.
Okay, I just have one more thing to add, that it should be gender specific at all steps, and there has to be sensitization for this, and make survivors share those stories, share positive stories, and change the image that TB, I mean, it has been there for centuries, but it's time that we change that image, and it's time that we realize that it is curable. And once you end the stigma and its perception, TB can just be treated as any other disease. That's what I feel.
Thank you so much. Let me start by thanking my panel who made time again during the middle of the day, and also for the valuable insights, because I think each of these actually hits out at some level of the health system where stigma exists, and even also at some level of society where stigma exists. And if we can address even 50% of these points, I think we will see a radical change in attitudes, both public attitudes and in the attitude in the delivery of care, but most importantly, in the patient experience. Because what we often forget is all of this impacts the patient and the family at the end. And that is the most critical part. So when we expect patients to eat 6 months or 24 months of toxic medication, and like Saurabh and Yashwant were saying, it shakes you and you have no psychological support, and you expect them to bear the burden of stigma, that is actually criminal in a way. It's empathy, or what Yashwant said as sahanubhuti, are two key words that we need to take away from this discussion. Thank you so much, all of you, for joining me, and over to the conference organizers for the next session. Thank you.
Thanks, Sapan.
Hi, everyone. I want to thank the organizers for giving me the opportunity to speak today. I'm quite excited to talk to you about digital cough monitoring and its role in TB care. Cough is a hallmark symptom of TB. It is used to screen for and track clinical improvement of TB disease. Globally, cough is the one symptom that predominantly triggers the entry of patients in the cascade of care. But as we speak, despite the central role in TB control, neither patients or practitioners have the means to objectively quantify and qualify cough. But coughs do not all sound the same. They do not all have the same frequency or last as long or vary the same way between day and night. Cough is such a data-rich symptom that clearly is not used to its full potential. It feels intuitive to me that if we could just refine and improve the way we analyze cough, this could accelerate patients' entry in the pathway to cure and be such a game changer for finding the missing millions of TB patients out there. Recent developments in acoustics and artificial intelligence now allow us to make significant progress on this. Using smartphones and mobile applications, cough can be accurately monitored and recorded, what we call digital cough monitoring. The tuberculosis working group in Peru showed that the frequency of cough diminishes with therapy and that its circadian variability regresses as time goes by. A proof of concept that objectively measuring cough correlates with the stage of disease, as shown on the left-hand side. The questions we need to ask ourselves are, does cough correlate with treatment failure or infection relapse? Is there a specific pattern of cough which even predicts those unfavorable events? On the right-hand side, colleagues at the Wadhwani Institutes for Artificial Intelligence in India showed that artificial intelligence model can be trained to differentiate the cough of COVID-positive patients from that of COVID-negative patients. Can such model be trained to screen for or diagnose TB? How good would be this model if it was trained on an enormous amount of TB coughs collected throughout the world? To answer those questions, We need to start digitally monitoring cough in TB suspects and TB patients right now. This is the Hive Cough Tracker app, which is currently used within TB clinical trials. This app records human cough without recording background noise or conversations. It can easily track significant increase in the user's cough over time. This application allows users to share their cough data with loved ones or healthcare providers or clinical researchers as part of a study. I think it's extremely refreshing and empowering to have such an innovation that can now be deployed outside the laboratories, outside the clinics, in patients' hands and pockets on their smartphone. I'm part of a global research consortium currently deploying digital cough monitoring technologies within TB diagnostics and treatment cohorts. Our aim is to build a global open access TB cough database, which will allow the development and validation of artificial intelligence models so we can make cough count in TB care. If you're a patient, a TB practitioner, or a researcher, I invite you to join us in this effort. I also invite everyone attending this conference today to download such app and start monitoring their cough and learn more about their respiratory health right now. So once again, I want to thank the organizers for giving me the opportunity to talk about this. I think it's an exciting technology that we're going to hear much more in the coming years, and I'm looking forward to the rest of the conference. Thanks, everyone.
Hello, I'm Sandhya Krishnan and I'm a TB survivor. Today I want to talk about how TB affects people of all genders. As a woman with TB, I struggled with how to fulfill my role as a mother of two. I constantly feared passing my disease on to my children. For the first few weeks of my treatment, I couldn't even hug my kids. But for their safety, I knew I had to stay away from them, no matter how painful it was. TB affects men, women, and transgender persons differently. But all of us require the help of our family, our community, and our caregivers, doctors, nurses, and others, in order for us to fight the illness and its impact on us. TB affects people physically, emotionally, mentally, and financially, and they need our support. As a society, let's come together to support individuals of all genders in the battle against TB. For more information on TB, download the Talking TB app. You can also write to us on Facebook, Instagram, Twitter, or ShareChat.
Chavan, and I am an MDR-TB survivor. DR-TB treatment can be tough and long. When I was undergoing treatment, I realized that discussion around TB and the quality of care that is provided to patients often leave out the perspective of the patient completely. We as patients deserve high-quality care. Care that we define based on our experiences, expectations, and need. A few questions we could ask to ensure high quality of care could be: what is the form of TB that I have? Have I been given a DST? What are the most common side effects of the drugs that have been prescribed to me, and how can I manage them? What are the adherence techniques that are available to me? What are the government and other social and economic supports that I can enroll in, and how? Asking these questions will help you assess the quality of care that you are receiving and also enable you to hold the health system accountable in case you are not. High quality of care should be ensured for all the patients to make their fight against TB easier. For more information on TB, download the Talking TB app. Also write to us on our Facebook, Twitter, Insta or ShareChat.
Good day to all of you anywhere. I'm Nagesh Mistry from the Foundation for Medical Research, Mumbai, a co-chair for the panel for the India TB Summit 2021. And the title is Emphasizing the Inclusion of Non-Medical Determinants for TB Care and Control. Many years ago, Adam Smith and later Nelson Mandela stated that the most basic of obligations that any government should have for its citizens are water, food, education, power, translated to energy, and security that includes in a broader sense elements of urban planning, safe housing, pollution hazards, and the preservation of natural resources. The quality of these promote health, while a breakdown in any of these are responsible for occurrence and spread of disease. Therefore, prevention and care of disease go well beyond medical dimensions. For TB, the importance of these dimensions are reflected in key historical evidence. The rapid elimination of TB in Europe and after World War II through food aid via the Marshall Plan, the McEwen evidence of lowering of TB incidence in the UK before the use of drugs or vaccines by provision of good quality housing, the 30-year well-documented backward experiment also in the UK, which demonstrated how the comprehensive care of TB patients resulted in zero incidence of TB in a patient colony. And lastly, Paul Palmer's recent work in Peru, Lima, which observed that the same comprehensive treatment could treat severe DRTB disease with minimal drugs in these patients very effectively. Our control efforts in TB are currently focused extensively on quality assured diagnosis and treatment of TB. Recent efforts have just begun to articulate intersectoral convergence, but the road is extremely unclear and we run the risk of drowning in semantics. Through this panel, we hope to reinforce this evidence as to how the non-medical determinants of housing, nutrition, community mobilization, and comprehensive care planning can make inroads into preventive and curative aspects of TB care. In order of presentation, we have Dr. P.U. Pardesi, an assistant professor at the Tata Institute of Social Sciences, who will present the elements for safe housing for TB based on an undertaking with IIT Mumbai and Doctors for You. Dr. Anurag Bhargav, formerly of the Jan Swasthya Sahयोग Bilaspur, and now a professor at the Anupoya Medical College in Mangalore, is a long-term votary who will deliver his presentation on why we should consider nutrition as a drug for TB. Mr. Deepak Gupta, who has served in several ministries and was former additional joint secretary to Ministry of Health and Family Welfare, and also former WHO advisor, continues to be passionate about TB. He will share his efforts to end TB through a multi-pronged approach outlining the challenges he faced. And lastly, Dr. Vinayak Prasad, Program Manager at the WHO Tobacco Free Initiative and coordinator of the WHO's National Capacity Building Team, will expand on a tried model of integrated care at the primary level, converging tobacco and TB control measures. My co-chair panelists and I are very certain that the presentation will justify the selection of this theme today for the summit. We look forward to your attention and a useful discussion on how to bring non-medical determinants of health into a state of functionality for what is predominantly a social disease. Thank you.
Good afternoon, friends. I'm Dr. Pihu Pardeshi, and I am happy to be part of this India TB Summit. And today I'll be talking about the role of safe housing for TB care and control. And for that, I'll be sharing my research study carried out while I was working with the NGO Doctors for You in the resettlement colonies of Govandi Mankhurd area in Mumbai. So this colony has people who have been relocated from various locations in Mumbai because some development projects were coming up there, and they have been given tenements by the government. So this colony has a high burden of TB, and we have been trying various methods to prevent and control it. A few years earlier, our health service provider noticed a pattern that most of the patients were coming from a few specific buildings. When we mapped the addresses, we were shocked to see that, as you can see in the picture on the left, that maximum number of patients were from the buildings which was sandwiched or stacked on both sides from other buildings. So that was the trigger for the study, and we hypothesized. We already know that TB spreads through coughing and sneezing, it thrives in damp areas, and is killed by direct sunlight. So we hypothesized that it is possible that some of these buildings which are stacked from other sides are receiving less sunlight or have a lack of proper ventilation, and that's why maybe it's a breeding ground for TB. And we went on to investigate it further. So we built computational models of ventilation and sunlight access. We did household surveys. We studied the urban plans of the layouts of these buildings and colonies, as well as we measured distances between the two buildings. We looked at the area of the doors and the windows and their positioning in the house, and what are the interiors of that house. And we found out very strong correlations between TB and the architecture or the structural factors of the colonies. So the three colonies we considered were Lalubhai compound and Natwarparik compound in Govandi area, and PMG colony in Mankhurd. And as you can see from that Google Earth picture itself, the way they are stacked, we call it a sandwich pattern. So the streets are very narrow. So it is visually obvious that there is a lack of sunlight access and ventilation, but we went on to measure it as well as build computational models. So if you can see here in the table, sky view factor as well as daylight autonomy are the parameters for measuring sunlight access. And our study found out that Lalubhai compound and Natwarparik compound have around 20 to 30% of the minimum threshold that is required for a healthy and for thermally comfortable living environment. If you can see the diagram on the left, you can see on the 7th floor of this is the building model that we have created computationally. The red portion shows the maximum sunlight that is available, and if you can see, it decreases with the lower number of floors. And in this lower picture shows that the ventilation or the air velocity is highest near the door and the windows, but in the space where the TB patient might be coughing and living and eating and drinking and sleeping, it is very, very less because of lack of a window on the opposite wall. So those are the parameters which were important for a safe and healthy housing, which were missing from these colonies. Our household surveys, which were carried out in over 4,000 households, we found at least 381 households with one TB patient in the last 10 years. And we saw that just 5 households were there from the PMG colony, which acted as a design control for our study, whereas rest of all the TB patients were from Natwarparik compound and Lalubhai compound. So these colonies had a poor building plan, poor architecture, and they had a high burden of TB. And 80% of these patients got the disease after shifting into the colony. And through measurements and survey results, we found strong associations between occurrence of TB and family size, houses being on lower floors, the houses lacking exhaust fans as well as lacking openable windows. That means if they had a sliding window, the total area for ventilation was just 50 to 70%. However, a fully openable window would give complete 100% access to proper natural ventilation. So that was missing, and that posed a higher chances of finding a TB patient there. So that was kind of a risk factor. So these are all risk factors for TB, and this is what our study was able to establish. We kind of recommended from the study that in short term, at least there should be retrofitting of all these buildings with fully openable windows as well as exhaust fans for proper ventilation, as well as these colonies which are highly densely packed, densely occupied, they should be decongested. That means some of the houses need to be left vacant. The 100% occupancy cannot be allowed in these colonies. As long-term measures, we want to push for improvements in development control regulations that determine how a building will be constructed. And to point out, these colonies also are located very near to the dumping ground as well as a medical incinerator facility, which poses another risk for the lungs, compromises the lungs of the people who are staying there. So we also want to push for the inclusion of public health concerns in policy decisions. Just like we have fire safety compliances, the building codes and the DCRs should include public health concerns like proper ventilation and sunlight into their policy framework, and irrespective of whether it's a low-income housing or a market housing or a elite housing. So the take-home message from this study was that safe and adequate housing is a prerequisite for a healthy population, especially in the case of TB, which is a respiratory illness and requires ample amount of sunlight and ventilation. Thank you so much.
Hello, everybody. Many thanks to the organizers of this Survivors Against TB India TB Summit. This is the era of patient-centered care in TB. The WHO Global TB Report 2020 highlights the fact that more patients develop TB in India due to undernutrition than those due to diabetes, HIV, and smoking combined. Undernutrition is both a cause of tuberculosis as well as a serious effect of tuberculosis, which leads to a number of poor outcomes. However, the role of inadequate nutrition in patients with tuberculosis has been long neglected, and this is a medical, a public health, and an issue of ethics and human rights for patients with TB. My presentation, which is titled Nutrition Care is Essential and Needs to be Equitable and Accountable, is based on evidence from research as well as the experience of caring for thousands of poor patients with TB in India. Hundreds and thousands of patients with TB in India are at risk as I speak because of their coexisting severe undernutrition, and many of them will die an avoidable death. Undernutrition in Indian patients with TB is universal, with a low BMI being documented in more than 90% of patients with TB. It is severe, with an average weight in men and women which is nearly 17 to 23 kilos than the reference weights of healthy adult men and women. And it increases the risk of death 2 to 4-fold. Weight gain in the absence of nutrition support is poor, and therefore undernutrition tends to persist even after so-called cure in India. Undernutrition is detrimental for the patient both during treatment and after treatment. It increases the risk of extensive disease and death, as also the risk of drug toxicity and drug malabsorption. It delays sputum conversion, and an adequate weight at diagnosis has been one of the key factors predicting treatment success in even patients with XDR TB tuberculosis. A patient who has persistent undernutrition at the end of therapy has poorer functional recovery and return to high livelihood, and a higher risk of relapse, lung impairment, and even post-treatment TB mortality. The WHO finally released a guideline on nutritional care in patients with tuberculosis, which recommends that nutritional assessment, counseling, and support are integral parts of TB care, and patients should have access to an adequate diet. The WHO's multi-sectoral accountability framework recommends that commitment should be translated into actions, which should be monitored and reviewed, and this is a framework relevant to our initiatives in India. India has adapted the WHO guideline on nutritional care and support for TB in 2017 in line with our context and needs of our patients. I was fortunate to help coordinate this effort. The NTP has also endorsed a free-to-download mobile application which calculates the BMI, suggests action points based on the BMI, provides tips on counseling and information on food groups. The Nikshay Poshan Yojana is a direct benefit scheme launched in 2018, which provides 500 rupees per month as a cash transfer to enable a more nutritious diet. This is the suggested nutrition care pathway in India. However, there are many gaps at the moment. It includes assessment of nutrition status based on height, weight, calculation of BMI, and also recommends hemoglobin estimation. It recommends counseling for patients and families and community-based food support and monitoring for clinical and nutrition-related outcomes. We did an implementation project involving nutritional assessment and counseling in PHCs in a well-performing district in Karnataka, and we can clearly see there is much scope for improvement in the way we are assessing patients and recommending nutritional support. The Nikshay Poshan Yojana, with its cash transfer, is a welcome and necessary step, but not sufficient to address undernutrition in TB patients because of a number of concerns. There is the amount adequate to enable an adequate diet? Case studies from different states have indicated delays in disbursement. On the other hand, a number of states do provide some form of food support in kind, and field-based projects in MP, Odisha, and our rations trial in Jharkhand, where food support is being given in kind, have shown encouraging outcomes and many precious lives saved. The need for equity. This photograph is of patients in Chhattisgarh, many of them tribals, and this is taken in 2014 and not in the 19th century. The nutritional status of marginalized communities in India, women and people living in remote areas, are most pressing. And these patients have high prevalence of severe undernutrition. They experience more often problems with DBT because of lack of bank accounts, and may also require food support for a longer duration. Since these nutritional related initiatives have been launched from more than 2 years ago, it is time that they are reviewed to address the gaps in counseling and capacity for care of undernourished patients, that we are assess the impact on weight gains, deaths, and adherence, and we address the bottlenecks in implementation by modifying strategy. To sum up, undernutrition is a serious but reversible comorbidity contributing to mortality and morbidity in patients with TB in India. Nutritional assessment and care should be viewed as an essential component of TB treatment in India and not merely as an incentive or enabler. Nutritional support is showing encouraging results in trial and programmatic conditions in India. However, the current nutritional pathway has gaps. It would be advisable to provide food support in kind as well as financial support, and the program needs monitoring, reporting, and review mechanisms for nutritional assessment and support. Thank you very much for your patient attention. And it's my pleasure to acknowledge both institutions and people who have helped me in this journey.
Thank you, Dr. Nargis, for inviting me to this India TB Summit. And good afternoon, colleagues and our other fellow panelists. I'm glad to see Mr. Deepak Gupta, my former boss, here. So it's good to see old friends as well. So I would be speaking on integration of TB and tobacco control in primary care. I'm Dr. Prasad from the World Health Organization. I head the tobacco control program in Geneva. At the outset, let me just give some figures. I mean, we have 8 million tobacco-related deaths globally, and of that, 1 million are in India. So while we're making good progress in tobacco control in India, as you can see from the slide, tobacco use burden is still very high. So in about 12 years ago, the government of India launched the National Tobacco Control Program, and it's piloted in a few districts, but now it's a pan-India program, and efforts have been made over time to seek an integration with other programs where there are co-benefits, such as the National TB Program. So the association between tobacco and TB has been long established. And WHO and the International Union for TB and Lung Disease came out with a systematic review in 2007, which identified and showed that there is a strong link between tobacco smoking and TB outcomes, not just in infection, but in terms of mortality. The risk of dying is almost 1.6-fold higher if TB patients continue to smoke. So through this monograph, which we released in 2007, what WHO basically was pushing is that all the TB clinics where TB patients are treated should be fully smoke-free. The providers of support, the DOTS providers, and the other health workforce should be providing brief advice. That's where we could provide those 3 to 5 minute counseling, and then also provide treatment on tobacco dependence where it's available, such as NRTs. And then also to be using the TB network and the program strength for managerial decisions to overcome some of the systemic barriers. And we also started to document some of these gains. I mean, at the end of a 6 months TB treatment, we could see that if these brief interventions were provided, there were already better treatment outcomes. So what we can see is that given the strength of the TB program, not just in India, but in many other countries, the DOTS program does have the potential to support a number of tobacco users. Because when I use the word tobacco users, because we have 1.3 billion tobacco users in the world, and 8 million of them are dying. So in terms of the strength, to TB is a subset of the numbers which we have for tobacco. So we could see that the TOTS program could easily provide the necessary advice, which enable more than a million tobacco users to access the cessation advice, and those gains can then start coming in. And we saw some of these initial interventions way back in 2001 when Nepal introduced on a pilot the PAL, the Practical Approach to Lung Health program, where an integrated approach on TB diagnosis and treatment was being promoted, which could show that the gains could come quickly even through such a light touch program. And so let me just skip this. We go to the India program. So what we saw in the initial years was some resistance from the TB colleagues. And I'm saying this because I was very much in the Indian government when this tobacco program was launched. And the reason was that the TB programs was very robust and the tobacco program was nascent. So there was some bit of resistance and from the TB colleagues to seek an integration. So what we did was, in 2013, we ran a program on a pilot basis in 2 districts, and we could show that with very brief interventions, we could actually get more than 67% of the TB patients to quit. And so those gains are actually very high with just that intervention. So over the last 6-7 years, now we've seen a very good scale up and integration of the TB and tobacco program in India. And most states have a robust integration. But there are some states which still need improvement. So it actually basically means looking at some of the health systems strengthening pillars in terms of ensuring that training and service delivery components are integrated, which is all reflected in this slide. So for this year, when tobacco and COVID is still a global challenge and the risk of COVID-related deaths is higher because severity of infection is an issue for tobacco smokers, what we have done is to launch a global campaign, Commit to Quit. It's part of the World No Tobacco Day campaign, but we are running the whole year campaign. And the target is to get 100 million of the 1.3 billion to quit. India has 267 million tobacco users, so we have huge gain potential. So we are doing well in tobacco control, but we can do better. And this TB program can actually provide us a great platform to further scale up and support the cessation program, which we have launched earlier this year. So thank you very much. I'm hoping to see some good discussion on how we could further strengthen the TB tobacco integrated approach at the global level. The WHO TB department is working out a framework for a strategy on addressing comorbidities such as tobacco, alcohol, malnutrition, and some of the other which have been mentioned by my fellow panelists. Thank you for your attention.
I would like to thank India TB Summit for inviting me. And I'm very happy to be here. I consider myself for the last 2 decades also to be a TB warrior. And so I would like to help in any way that all of us together can help treat the TB epidemic in India. You know, in 1998, when I first joined the Ministry of Health and came to administer our TB program, I was shocked to find that India carries the world's greatest burden of TB. And even now, we account for 27% of the world's new TB cases and almost 29% of the TB deaths. So on us and India especially falls the responsibility of treating this disease to help the world, not only ourselves. You know, in 2014, the World Health Assembly set very ambitious targets in its end TB strategy to reduce reduction in TB deaths by 75% by 2025 and reduction in TB incidence, which is the real measure, by 50% by 2025 and 90% by 2035. But the government of India has gone beyond this and sought to end this by 2025. Actually, some given targets for earlier than 2025, which of course are very difficult to achieve. So I think these are kind of aspirational goals and which provide a kind of inspiration to all that we have to redouble our efforts to treat the TB disease. But this kind of a target or even coming closer to the target would actually require us to detect all possible patients coming out in the country because we have to reduce our rate of incidence by almost 10-12% to achieve any kind of this target. And this is not easy to do. So I would like to try and talk a little bit about what is it that we can do to increase our detection rate. My own feeling is, and my experience of being in the ministry and since then, that we have to focus on urban slums. Here the incidence rate may be even higher than 300 per lakh. So we have to find a saturation approach kind of activity for the urban sector. And we find some gaps. So it is essential that we cover these gaps as also identify, possibly through GPS and modern technological means, to identify clusters within slum, and then full attack on these slums, on these identified clusters. So one of the ways to help access is to communitize the program, and therefore a large number of community volunteers are needed. And I believe, based on my field experience, that treatment kiosks, if they are set up at different places and suitable locations within the slums, this would help. For time, there was a cobbler in Karnal district who was treating 50 TB patients, and all he had in his house was some leather and shoes and TB treatment boxes. We also have to ensure that all non-health institutions like the army, the ESIC, mining, railways, etc., they're all fully participating. Last year, I went to Bokaro and Ranchi, and we had a detailed meeting with Coal India. And I found that many of the mines cases were missing because they were not fully involved. So we have to ensure that all these are fully participating. We also need to ensure that all NGO hospitals, whether charitable, trust, whatever, they have a lot of OPD and they have a lot of TB cases. I remember in our days that Varanasi and Bareilly NGO hospital, they produce so many patients. And so we have to ensure and possibly monitor each big hospital as a single unit so that, we are able to find out where are the inconsistencies and where are the problems. It will also help if a group of volunteers between doctors, civil servants, and some from the civil society, if they could act as a task force, go to the field, examine what is happening, possibly identify gaps, make some suggestions, and give feedback to the government. I found that this thing works very well. Finally, I think it is very important that, molecular testing is done for all the people in these slums at a saturation approach. And as we have learned through the pandemic, we sort of do more testing, and we contact tracing, and we do preventive action. We have a TB NAT machine now. It is much cheaper than the older one, which was discovered in South Africa. And I think we have to saturate the machine and do full testing for all these kind of niche areas where we may be having a large number of cases. So we now also have preventive treatment possible, so contacts of such patients. And maybe as another lesson from the pandemic, anybody gets a cough, he of course must immediately report somewhere through the system and wear a mask, and somebody should reach him, somebody should get him tested, and he is put on treatment, and we do the contact tracing, and we put the people either through the screening process or preventive process. So we have to do a series of things simultaneously in a very, very intensive public-private partnership kind of way with very strict supervision and monitoring. And I'm sure that this will remove the stigma, this will bring all the people into the system of diagnosis and treatment. And one thing will lead to another, and we will be able to achieve our goal of detecting all the patients. So that is my suggested approach. It is very important that we succeed. And I wish all of you and all those who are fighting TB to work together and deal with this effectively, with this problem. Thank you very much.
Hello everyone, I am Diktendu Bhattacharya. I am the co-chair of the panel titled Emphasizing the Inclusion of Non-Medical Determinants for TB Care and Control. On behalf of my co-chair and our organizing committee, I would like to thank our eminent panelists for these wonderful presentations. The insights are many valuable lessons for us, those who are persistent to believe that we can defeat TB. This disease lingered with humanity for too long, which we believe cannot be defeated only by medication, especially in a high-burden developing country like us, where financial constraints play a role. Only serious policy changes, like our speakers have pointed out, can win 2 races in one run for us. We would like to thank Dr. Pardesi for highlighting the role of housing, which is historically evident and realized long but marred by erroneous policy. We would like to thank Dr. Bhargava for his talk on nutrition. I realized the importance of it during my treatment. Mr. Gupta has presented what policies are in effect and what policies can be included to fill the gap in achieving the ambitious goal. We thank you, Mr. Gupta. Last but not least, we would like to thank Dr. Prasad for bringing a concern to our notice, which is easily overlooked, the role of tobacco control. I personally felt this is a much difficult task to be addressed. On behalf of my co-chair and our organizing committee, I would like to thank you once again for giving your effort towards the success of the meet and also for your invaluable time. I now open the session for Q&A. Thank you.
Hello. Hello. Good afternoon. I think we're missing Anurag. Anurag, are you there? Yes, there you are. Okay. So good afternoon, panelists.
Hello.
Good afternoon, Diptendu. And thank you once again for a lovely presentation and a nice session. I hope everyone in the audience has enjoyed it. So I think we'll start with the live discussion session. And if I may just start by just making the remark that all the panelists touched upon what politicians know quite well during an election. They promise roti, kapda, and makan. And I think what the panelists here have actually highlighted is roti, hawa, makan, and soch. These are the 4 elements that the non-medical determinants which the panelists have highlighted in this session. Of course, I think you must realize that we have more non-medical determinants that what have been handled in the session. It means like health, education, sanitation, environment, economics. Their role in health is not unknown, and several studies have actually dealt with all these. But still, despite the evidence building up, why do we see so little focus on the non-medical determinants? We only talk of treatment in TB and diagnosis of TB. So if the non-medical determinants are considered important, why are we reluctant, or why is the system on the whole, not only in India, but also in many other parts of the world, why is the system so reluctant to address it with the same priority? Yeah. If anyone would like to join in, or somebody from the audience would like to answer, or the panelists, that would be fine.
I don't know who has to answer this question, but
anyone who feels you wants to say, please answer briefly.
I think this is a generic problem, not related to TB alone. There is a general neglect of preventive health and the non-health determinants for health. And we have been trying to argue that we need a change of mindset and we must give the primary importance to, and therefore drinking water, therefore sanitation, the better cooking systems in rural areas, the housing kind of arrangements that we have are absolutely critical. And I think the larger society, and Vinayak is sitting in WHO, and this is a role which WHO also has to promote, and all of you in the private sector, that we as a society give importance to these kind of factors. And by the way, this is not only going to impact health. We are going to face a huge crisis of energy and all these things in the coming years, and this will impact that area as well. So I think we all of us should make an all-round effort, comprehensive effort to focus on the preventive side and other things. And this is not for it is for general health, and I think it's not so important and critical for TB as such by itself. So I think that, and maybe Vinayak may like to add that what WHO should be doing, because we are overemphasis on curative medicine, and pardon me, for specialist treatment is dangerous for the country. It's not leading us in the right path.
So maybe, Nargis, I'll just build on what Mr. Gupta said. And thank you, sir, for that flagging that the prevention issues are not on the radar. And even if they are on the radar, you will realize that most of the comorbidities require a more broader engagement with the government. It's not a health-focused engagement which will work. I mean, in the case of tobacco or alcohol, or even malnutrition. So if you look at all of the comorbidities which the Global TB Report of 2019 identified as challenges, these are all requiring attention of not just the health minister, but other ministers. And then also on the point that even smaller interventions actually do make a big impact. But somehow as part of the TB program, they have not been very aggressively pushed. It took us about 10 years for tobacco control to be accepted as part of the TB program in India. So that's that lifespan I'm seeing. Even alcohol may have the same challenge to find acceptance for brief advice counseling by the DOTS providers and basic interventions, which have huge successes. As I've already looked at the Indian success, but even look at Indonesia or Bangladesh, if just the brief advice counseling leads to more than 70% of smokers to quit if they are during the treatment phase. That itself is a big gain. So I think those are simple interventions which we can really work on, but we will really need more of whole of government engagement if we were to succeed, because how do you raise taxes on tobacco or alcohol unless until you have the finance minister wanting to do it? So those are things we need to look at, and TB program is quite well placed in India to push some of these narratives. Thank you.
Thank you, Vinayak. Anurag, yes, please go ahead.
Well, I would say that we create a dichotomy when we say non-medical, and from the very beginning. And somehow the TB has always been viewed as a disease of poverty, which can be addressed by social welfare measures, whether it's housing or nutrition. And the historical experience of the Western countries, clearly proves that TB rates fell down before the drugs were discovered. But somehow around the 60s, when the question came of implementing TB programs in the developing countries, the focus narrowed down only to case finding, treatment, and to a certain extent, which we never take up, chemoprophylaxis. So it had become very infection centered to begin with, and completely, even within the patient, whether he's undernourished, whether he's a smoker, whether he's drinking alcohol, or whether he has a drug resistant disease itself. These things sort of never came to our whole attention. It's only now that we have articulated patient centered care in TB, which should be actually something obvious. So if the person, and I think there is no dichotomy between a patient-centered approach and a public health program. It should offer the standard of care, and it is possible, as we've seen in HIV, the two things are possible. But somehow in TB, it has been still lagging behind, and we cannot afford to neglect these aspects anymore now, because they are completely interrelated.
Thank you. Thanks, Anurag. Diptendu, would you like to take the next question?
Yes, ma'am. My question is to Dr. Pardesi. I am coming from a city which is quite a bit old, and I am living in a part which is getting a status of heritage. So here the buildings which is some 200, 300 years old, and people are living there, and those houses are once held by some elite, and now they have many ancestors clubbing together on in those houses. And the modern, currently developed area are sparsely populated or spread out over an area. But the older part of the city, I guess this problem happens in your studies also. You have studied in Bombay. Those kind of areas, we are seeing that more frequency of TB cases are coming out. Is there any way to reimagine the city planning, keeping all those heritage emotional attachment alive and relocate, or any way so that we can stop this breeding ground to remain as such for the future?
Thank you for your question. I hope I'm audible. I am no urban planner as such, but I will just say that one aspect, like from my own study that I observed, was that if there can be kind of decongestion, so we don't have to have 100% occupancies, and we can kind of space out the buildings. Even if they are heritage buildings, we don't have to occupy them 100%. So if that is one way we could imagine. But in general, yes, it's a messy procedure, because all the cities are now expanding. So earlier, even if we thought that now the major problem with especially Mumbai and other mega cities is that they just came up one project at a time. They were not planned. The urban planning was not done. So had they been planned, like nowadays we see some kind of townships are coming. I am not commenting upon the quality of health over there, but I'm just saying that if that mixed housing colonies can be there, where people from different socioeconomic strata can stay in the same colony and will have a proper within the same space, the architecture can be imagined differently, and people are already doing it, so that at least the angle of the sun is such that every floor gets enough sunlight, and the positioning of windows is such that there is ample cross ventilation, and that does not require too much artificial use of fans or ACs. So that kind of imagination is already happening, and I think more scientific approach towards this has to be taken, rather than just aesthetic beauty to the building. We need to look at more public. So that's what I said. If we take in the public health policy concerns, or public health concerns in imagining these cities, that's how we can make them safer. But to things that have already come up, there can be only some kind of retrofittings that can take place. Maybe exhaust fans, maybe some better windows, but all this is a piecemeal approach, and that's why it's messy, because we don't really know whether it will solve the problems or not. So that's what I can say here, because this is what I have observed, that we as scientists, or as anybody, as a professional, we may suggest something, but what do people really want is the question. Because just last week I was talking to some of the community leaders, and they are like, okay, leave the window aside, the TB is not the only problem that we are suffering with. So we are also suffering from typhoid. So why don't you get the pipeline corrected? Because instead of a 12-inch pipe, the government has fitted a 9-inch pipe, and it is bursting every now and then. So all we have is typhoid and cholera and malaria and dengue. So that is our primary concern. So unless we look at it holistically, it's very difficult to imagine how to build better. Thank you.
I
That's the
may just
problem.
say-
If you look at things only sectorally or
Yes, that's
just
right.
one disease, because architecture of housing has implications for many more important areas.
Absolutely.
And green architecture, for example, will take prominence over something just meant for a disease. So these are some of the problems. How do you address different priorities?
So if I may just chip in, Pihu, to a very insightful comment you made about this. In India, there is very little emphasis played on health aspects of architecture. Yeah. And there have been no norms actually laid out. The governments of, say, Hong Kong or the UK have invested huge amounts of money in safe and healthy housing. So this terminology, healthy housing, which not only for TB, but for every disease, it's just about coming into vogue nowadays. And you see a lot of these builders advertising healthy housing, but that's for the wealthy. Yeah. So what about the norms for the low-cost housing? And that is something that needs to be brought in a very urgent way to address not only TB or any other respiratory disease that we may be faced in the near future, but also other respiratory diseases that will be coming about very soon, perhaps, because of the degradation. Yeah.
Yes.
So I think that, and in fact, when I measured some ventilation in some of the slum housing in Mumbai, when it was one air exchange every 15 hours, one air exchange every 15 hours in a room where 5 people slept in the night. Yeah. So you can imagine what is the type of carbon dioxide buildup and the air pathogens. And that brings me to the question of pollution. Yeah. So the pollution is also connected to this, and it's also rampant in the cities along with the congestion. And would anyone like to comment on what is the regulation in air pollution that needs to be gotten? Of course, it's all there on paper. The last budget actually even addresses that to some extent about putting in more money into renewable energy sources and so on. But are we going to see the light at the end of the tunnel, at least for trying to regulate air pollution? If somebody has a comment or thoughts on it. I mean, we're not here to answer questions, but just to ventilate on the problem.
I think the situation in the near future about air pollution in cities does not give us great optimism, because we are increasing the number of cars and the emissions. We are unable to tackle things like stubble burning. And since I'm personally involved in these issues, I can tell you that there are solutions for stubble burning, but we are not, unfortunately not. And this is another issue which people should consider why it is not happening. So things like air pollution, I'm afraid, are not going to help us in reducing health issues and TB, etc. in the near future. Possibly that is why we have to emphasize on the detection and treatment of cases.
Sure. Thank you. Diptendu, are you there? Yeah. Would you? Hello? Diptendu, you're muted. Okay, if we can't get Diptendu online, Anurag, could I pose a question to you? Do you see any seminal steps being taken in the near future to promote cash and nutritional security? You mentioned some points of what needs to be done. So, but is there any step in that direction? Because of the urgency of tackling.
Yes, so I think the Nikshay Poshan Yojana is a step in that direction, but as I indicated in my slide, in my presentation, it needs to be reviewed whether this degree of support is being offered in a timely manner, whether it's adequate, and it is being used for nutritional purposes. So I think the model that exists in many states in India of both financial and nutritional support is, I think, the way to go. Many states in India, almost 14, are offering some kind of nutritional support, but at the moment it's being restricted, for example, to MDR TB patients. When we talk of nutritional support in TB, we have to treat it as a medical problem. Just imagine that we are detecting diabetes and HIV, for which we are committed to offering lifelong care. In the case of nutritional support, we are talking of support for a few months, which will take care of this morbidity, which is actually killing a lot of patients. So I think because especially we have to reach the mortality target sooner than we are going to achieve the incidence targets, I think this is a low-hanging fruit. If we identify the undernourished in India and the severely undernourished and provide them comprehensive care, including nutrition support, we are sure to see a decline in mortality very, very soon. And some of the experiences from the field, including our own trial, are indicators of this trend, that that it can significantly help in achieving our NTB goals of mortality. And the highest incidence of TB in any population is in the household contacts. So if they are undernourished, if they are food insecure, then the transmission is continuing within the household itself. So I think we have in India one of the largest kind of supplementary nutrition programs in the world in terms of our ICDS schemes, the midday meal.
Portion 2.
Yeah. And I think if the PDS starts providing some quality protein in pulses form, it will be easy to link the TB program with these existing mechanisms. So I think both these components should be given importance. I'm happy that it has at least come on the map, but we should build on it. Yeah.
Diptendu, would you like to take on the other question?
Hello.
I think we've...
Am I
Hello,
audible?
Diptendu? Yes, you're audible. Would you like to pose another question?
Yes. Actually, my network is little bit breaking.
Yeah, if that is so, then could I just request Dr. Vinayak to answer one of his sharp observations that he made during his talk on the fact that when he tried to bring in the tobacco control into the TB program in India, there was resistance from the TB sector. And now that we are trying to sort of bring in other elements also as a sort of a comprehensive care that Anurag mentioned into the picture of bringing NCDs, mental health, and others. What do you see as the challenges in bringing in comprehensive, even primary health care for that moment?
So my narrative went back more than 10 years. So that by that time, the TV program had become evolved, whereas tobacco or other programs or NCDs were not evolved. But things have moved on in India, which is good, where the tobacco program is also quite mature. So this is a good time for us to seek the NCD interventions. I mean, given that tobacco followed by alcohol, and then on the other side, diabetes management, prevention and management are so crucial amongst the 5 key non-TB kind of determinants, which you could have huge gains. It will be good to focus on that. And what we've seen is that it takes a bit of an effort at the state level. Some states are doing well in terms of integration, given our structure. So just sitting in Nirman Bhavan and trying to get the TB folks to do this doesn't work. And that's an important lesson, that some states where we have strength, both from the tobacco program and TB program, we should seek that integration. I am not sure if the alcohol program has any similar kind of an approach. Because again, if you see, that's again a very important area, which I think needs to be considered. In the case of diabetes, it's become a global issue. A global diabetic compact is being set up. And India is, as you all know, has a huge challenge with diabetes in terms of detection. Most cases don't get detected on time. And again, that is something we need to seek in terms of integration. So in WHO, TB department is now coming out, as we call it, global goods, is a kind of a framework to seek that integration. So I hope some of those lessons from India can be put into that TB comorbidity strategy, which is likely to be developed in the next 3 to 4 months, will be helpful. India can really be able to, at least the challenges need to be discussed, because it's not just only tobacco, but also the others. So we need to discuss that, and that discussion needs to happen. So how do we have that robust discussion with the TB focal points at the state level along?
Oh, I think everyone's gotten mute. Dr. Vinayak, yeah, okay, right.
Were you able to hear me?
Yeah,
No,
now
that's fine.
we can hear you now.
We can hear you now. Yeah, for a minute you had gone mute. That's fine.
Okay, so my last comment was that we need to seek full integration, and that's only possible if you have state level discussions where you invite the tobacco and the NCD focal points for a robust discussion on what is practical and what can be done. The Nirman Bhavan Health Ministry discussion sometimes doesn't translate so quickly. It takes years. And I'm talking from my own experience, and Dr. Gupta, my former boss, can allude to it. It takes years. How do you, so you can short circuit that by trying to create states championship. And I think that is something which we really need to think through. Is there a state which has shown this integration? Is there a state where there is a common vision? If there is, then we need to show that. And that's what seems to be working at global level, looking at country championship. India is so big. Can we get a state champion?
I remember yes. I remember a committee that I attended some years ago when I was considered as one of the advisors. I think it was Keshav Desiraju was the health secretary at that time. And this was a unique sort of thing where about 23 different ministries sat together on the table and actually discussed several health decisions. And there were some very sharp comments coming in from the other non-health ministries also on several moot points that were there. So if something like that can be formulated within government again, to have this, we've seen in the EU particularly, I think has shown a good example that the best type of convergence takes place when interdepartmental heads talk to each other and start discussing matters together. And of course, to bring about intersectoral convergence, you also need to have universal access to this non-medical determinants. And there comes the important thing of putting investments. Yes, please do, sir. Of course.
Actually, what all you people are addressing is a big problem if you are in government. Because whether it's a state or the center, and particularly a state, there are so many health problems which you are confronted with at any given time, with a shortage of both financial and health manpower resources. So to go so deep and to issue coordination, the TB has been dealt as a technical problem all this while. We try to make it a managerial problem. I mean, just shift away from TB as a program to make it a manager. The district TB officer should be a manager, not a district TB officer.
Not a district TB officer.
So there are a lot of issues. So one possible way out is where all of you, civil society, and those people who are willing to contribute, let us take 2 wards in Bombay and let us make an experiment to bring in all our efforts of all people combined for alcohol, for tobacco, for nutrition, and see over 5 years if it makes an impact. I think we have to think like that, because, you know, just nibbling at the edges, we may talk about it all the time. I mean, I'm just being realistic. I was a very passionate person for TB, and Vinayak knows that. But how to get all these small elements into? I need to do the coal miners. There is a problem there. I need to do about indoor air cooking in rural areas. How to get all these involved is a terrific problem. So try that one pilot and let WHO study it. Maybe it can be done in 2 cities, one in India, one in some other country.
Yeah, that's a good suggestion, Mr. Gupta. Thank you. Diptendu, can you come in now?
Okay.
Go ahead, Anurag, go ahead.
Yes,
we seem to have lost him. Go ahead.
Yes, ma'am. Yes, ma'am. I'm here.
Yeah. I think Anurag wants to say something, and then you can follow up, Diptendu, and perhaps bring the session to an end, because I think we're running out of time now. Yeah.
So the only
go ahead.
I teach in a medical college, and I think the essential problem is that we have not equipped our basic doctors and our paramedical staff with the skills of, eliciting this information and counseling. These are very key things. I think we do not require specialized skills for all these things, because a primary care provider should be able to ask about alcohol use and tobacco use at every contact. It's like a vital sign. And the 5A approach that Dr. Vinayak referred to is well within the capacity of somebody at a primary care level to organize. And then if you have a continuum of care of somebody who is requiring some special attention, then he can be referred. But thinking that we will be referring all diabetics with TB to a NCD clinic, and then for other specialized things to other specialized clinics, it is not workable, because we have limitations of resources. So equipping our primary care providers is where the integration will all occur, and this will be useful not only for TB, for all NCDs. So it's not something which is TB specific, it's a TB sensitive intervention.
Thank you, Anurag. I think there are questions from the audience, but perhaps we are sort of nearing the time limit. Diptendu, would you like to just make the closing remarks? And I hope that the questions that have been posed by the audience can be sent to the panelists, and if they could care to respond to the question, that would be wonderful. Thank you. Thank you all. Diptendu, please make the closing remarks. Yeah, thank you.
Yes. Sorry for my network disruption going on during the panel discussion. I actually have some remarks about the city planning. What I have seen that not only the urban centers are dense, but the transportation towards the urban center, because the jobs are around the urban centers. So the migration is one direction. If we can plan the city like a satellite city and spread out the job centers away from the city, so the transportation may be somewhat decongested. In that way, we can limit our community spread to some extent, like what level it is right now. We can decrease it in that way. So there was just an observation. I don't know how much significant is this observation holds.
Well, the urban trend is towards
decongestion, as Dr. Pardesi mentioned. I thought this might be a helpful suggestion around that. And another one is that from a person from research background, and I have understanding about these issues even when I have got contracted with TB. But the thing is, the common people doesn't understand, or they don't see these things like way. But our country is a democratic country, so people need to identify the problem and demand for those. So I think the public awareness or public education regarding this kind of policy demands must have coming from people like us who have suffered and who has awareness about this kind of policies, or this kind so that we can make sufficient demand for to the policy makers. So if the non-medical medical treatments are demanded by everybody because that was a basic need, but this kind of changes requires both side involvement, not only the policymakers but those who are receiving at the receiving end of the policies. So to include all the stakeholders for better involvement. Thank you, panelists.
Thank you to all panelists. Thank you once again for your effort in the presentations and for being here and for a very lively discussion. Thank you very much, all of you.
Thank you.
Thank you.
আমি অনেক কিছু করার চেষ্টা করলাম কিন্তু সেটা রুমটা বড্ড ছোট।
Good afternoon, everyone, and welcome to this session on life after TB. And I'm so thrilled to be here and very excited to have my fellow panelists here with me. And I'm going to ask each of them to introduce themselves in just a minute. If everyone could please mute themselves. Arup, if you could mute yourself, please, till I call on you to speak. Okay, here we are. I'll introduce myself again. I'm Sandhya Krishnan. I'm a wellness coach, a TB survivor, and a fellow with Survivors Against TB. I just wanted to start by saying that we've spoken a lot about problems that survivors have had with diagnosis, with stigma, with the entire process of going through medication and the disease. But this is a session that is to give each survivor here and their families hope that life does go on. We do come out on the other side, and potentially we could come out much stronger. It takes time, but just for you to know that you are not alone in this process. And it really, really does help to have somebody that's been through a journey much like yours, in a different way perhaps, but who understands the pain and understands the suffering, to be there for you. And that's what we do at Survivors Against TB. And this is really just our all of us sharing how life restarted again for us. I'll just begin by saying two salient points. Initially, once I overcame TB, my single point agenda was just to build my strength again and then get right back to life and work and everyday living. My turning point really came when I heard one of the SATB fellows speak at a TEDx, Dr. Saurabh, and I realized then that TB had touched me in a way that I could not deny, and also that my personal journey was so lonely, and knowing that there were people out there who'd been through something like I did, and who came out and sounded so positive, I felt that if I could give that help and that support to even one other person, then, and if I didn't really, that I would be failing in this sort of second lease of life that I got. And that's how I joined SATB, and I haven't regretted it for a minute. The second big realization that I had was that in rebuilding our lives, this is again a chance for us to look at it from a holistic perspective, and that we can't afford to ignore any aspect of our wellness, even with the busy lives that we have, even with the stresses and the financial constraints that we might have, how we can, in simple, small ways, invest in our relationships, in our mental health, in our nutrition, in our financial health, and just in a sense of larger purpose, gratitude, and giving back in however small a way. And I've seen this across strata, so I do believe that this can be done, and that these are some of the conversations that we would like to have in this session. So without further ado, I'm going to call on each of my panelists to introduce themselves, because they each bring a really, really special aspect and of thriving after TB as part of their story. So it's over to you, Arup. First, tell us a little bit about yourselves, about yourself and your life after TB. Arup, can you hear me? Okay, I think Arup is frozen. Why don't we go to Prateek? Oh, okay, he's back. Arup, can you hear me? You're muted. You'll have to unmute yourself.
Yeah, my screen had gone blank. Good afternoon, everyone.
Yes.
Namaskar. It's actually a pleasure because, being a TB survivor and seeing all of us, suffering in the same way, gives me that much more assurance to, tell the world that there is nothing to be scared of. I'm a twice TB survivor. The first time when it happened, I was absolutely alone. I was thrown out of the house, and Mother Teresa had to rescue me, and I was in a home for some time before I went to a sanatorium. Luckily, after I came out, my wife, who I was dating, she didn't leave me and we got married. The second time when I had a relapse, both my children unfortunately contacted TB. They are absolutely okay. I'm okay. And I'm so proud to be with y'all today. And I'm actually otherwise outside this forum spreading the gospel through my NGO that, TB is nothing. It's nothing. Carry on with life, take it forward. So leave it to all of y'all. That's me, 71 years old, COPD patient. I carry an oxygen mask. The mask is just down there, but I'm just roaring to go with y'all. Take it forward, please.
What an inspiring story, Arup. We're going to hear more about that in just a bit. It's over to Prateek, our recent SATB fellow. So happy to have you on this panel, Prateek. Tell us about your life after TB. I'm going to ask you later about your life with TB as well, because we haven't heard your story.
Right. So first of all, thank you so much for having me on this panel. So I contacted TB in 2019. Then post that, like, it was a surprise for me because never ever have I heard about anybody in my family who has contacted TB. Nobody knew about how to go about it. So it was a surprise for me and a shock for my family as well. But life after TB has been, I mean, it is just like it was life before TB. I don't see any changes in my life. In fact, there is a lot more positivity, as Arup sir said right now, that there is a lot of positivity about other problems as well. Whenever I face any problem, so I see that if I fought this TB, then I can fight anything in my life. So that is something which I have learned from this TB. And I was a brain TB, so I'm a brain TB survivor.
Yes, that was part of your very unusual story. And you're an MBA. You're an MBA graduate student.
Yeah. So I'm a first year student.
Okay, so you managed to continue with your MBA course despite contracting TB.
No, actually, so as I said that I contacted TB in 2019. So and it was just 40 days into the curriculum, so I had to take a drop on the advice of my doctor. So I took a full year rest. It was a time of like recollection. I learned few things, and then when I finally got over and the doctor gave me a green signal, so I joined back my course.
That's amazing. And I know that it wasn't sort of like all roses for you. You had a loan out for your college and everything. Wasn't that scary for you, Prateek?
Yeah, so scary in the sense of like the year 2019 started with high. So I was like on the top of the world. I was joining a good college and everything was like really good for me. But then suddenly after 6 months, it was such a low time. And I was scaring because I was on an education loan, and then there were many uncertainties that I was thinking in my head that what will happen if my college does not allow me to join back? What if the companies do not recruit me because of my disease? So there were many things. But right now I see I am going as an intern in a very good company, and I have like very openly told them about my disease also. So they were very welcoming. So all the apprehensions that I had that maybe people would fear taking me in. So that was all in my head. In the real world, it is not that wise. So everybody is quite welcoming now.
Yes and no, but you're absolutely right in that very often the fear is of untoward occurrences or the negative happening or the worst case scenario happening, and we saw that with COVID as well, right? That fear is what holds us back very often, and once we learn to face that fear and just take that first step forward, we'll often get the kind of support. A very, very powerful message there, Prateek. We'll come back to that and hear more about that story, but it's on to our next survivor to introduce herself. Hello again, Ritu. We were on a panel together yesterday. Ritu is also an SATB fellow and a consultant. Go ahead, Ritu. Tell us about your TB after story and introduce yourself. Yes. You're muted, Ritu. So
yeah. Hi, Sandhya. Thanks so much for inviting me again. So my name is Ritu, and I work as a strategy consultant with Boston Consulting Group. So this is my post MBA job. So life after TB, I think, has been far better than what I had before TB, and I think there are three reasons for it. One, I think I'm much more confident about my capabilities now. Having defeated a deadly disease. I think now if I face any problem in my life, in my work, in my relationship, I'm like I'm much more confident that I will be able to sort it out. Second, I think I value my relationships far better than what I used to earlier. I'm grateful towards my family, my friends who supported me throughout my TV journey. Like they were with me from start to the end of my journey. And third, I think I'm also able to manage my health and professional goals equally well, Earlier, I always used to prioritize my career over my health. Health used to be at the back of my mind. But now I think health is equally important. Despite whatever, number of hours I work every day at my office, I make sure that, I also give, 30 minutes of workout time. So I work out regularly. I make sure that it is at least 3 to 4 days a week. So yeah, I think far better than what I was before having contracted TB.
Thank you for sharing that. Thank you for sharing that. I know yours was not an easy journey by any stretch of imagination, but that you've come out so much stronger. It's such an inspiring story. And I hope it gives hope to those who are listening and those who might be struggling and not feeling very much hope at this moment. Thanks, Ritu. Over to Kayuri. She's an SATV fellow as well. And I think we all were nodding vehemently when Ritu was talking about the importance of exercise. I know Kayuri is another person who values her health. Kayuri, if you could unmute yourself and tell us about your life today and your post-TB journey.
Actually, thank you for inviting me. I'm a content writer with Pictorial Pundits, and also I'm an active TB activist with Survivor Against TB organization. Life after TB, I have realized much that how much we are unconscious about the time we spend, and we don't take an account of the moment we spend. Now I'm very much conscious, and I make it a point that whatever time I spend, it is a conscious time. It's not something I am just wasting here and there, because I have realized that your time is not going to come back. It's gone forever. So that's what I've learned. And now my after TB life is more like conscious and in a control, and it doesn't go away like this. I don't give away my time for no reasons to anybody. I make it a point that I keep it for myself, and I make it a point that I give it to the people who need it and who can learn something from my journey, so that they don't fall in the same trap. So that is it.
That's such a powerful statement. And also, from a neuroscience perspective, we have something called a body budget. We literally have finite amount of energy, and a lot of that energy just goes in keeping our body running, right? Especially when you're recovering from disease or recovering from like a recent stress in your life of any kind, which our everyday life does throw at us. So we really need to honor ourselves by apportioning enough time first and foremost to ourselves, because if we're not whole, if we're not healed, we're of no help to anybody on this planet. So to be able to prioritize that, no matter what stresses and demands we have, there are on our time. And I know that all of us here are juggling multiple things. Arup, I want to come back a little bit more to the work that you're doing. I know we heard your story yesterday via the movie and about your corporate career, but I would love to hear how you're spending your time these days. And thank you for that introduction, Kayuri. We'll swing back to you once we hear about Arup's and I think his banner in the background will tell us a lot about what his day-to-day activities revolve around. Over to you, Arup, if you can unmute yourself.
Thank you. Notun Jivon in Bengali means new life. My new life actually started when I met Mother Teresa in 1968, when I was thrown out of the locality. So my journey started there. In the first 4 days, she didn't have space in Nirmal Hriday. In fact, right now I'm shooting just beside her ashram, from where it all started. So I was on the footpath for 4 days, and I realized that what it is to be poor. That's the point. It pricked me, and I made a vow that I would do something about it. I didn't know how at that time. I was just 16 years old. Climbed the corporate ladder, and as I started climbing the corporate ladder, I was doing very well, okay, because the sickness and all my other friends and absolutely young friends told me that they went into health, they went into exercise, they were more conscious of living. And that applied to me also. Like every second I was praising God and myself, that thank you for keeping me alive. And I was utilizing it on the footpaths of Kolkata, feeding children who actually sleep in the night, and they're the most suspect to get the sickness, because rain, shine, or any weather, they are out there without any defense. And that's where my gospel of teaching them, basic hygiene and signs of, if you have fever, what you should do, which are the hospitals, put in doctors into these camps. I have 367 children who are on the footpaths, and we made it a point that every day, 10 o'clock in the night, myself, my co-trustee Jhumki, she's just 41 years old, her daughter, who was 15 at that time, and a few others. My wife was alive at that point of time. I lost her 2 years ago. So we went out onto the roads preaching, and now today, I have a school inside the red light area. Now that's another very high risk zone of this particular disease or COVID, because they work under extreme hard condition, 6 feet by 6 feet cubicles. So the children are in our custody, in our care, and that's why it's just about a walking distance from here. We go there every day, give them food. Food is one of the things I learned. Good nutritious food keeps any disease away, and that's exactly what we do. And in Sundarban, I am building a school, 225-seat school in an island which is not accessible per se. We have there a hospital which is coming up, and also 100 the thing sewing machines as livelihood for the widows, because their husbands are taken away by the tigers, crocodiles, or snakes. And I have uprooted myself from Kolkata, and I live in that island. I live in that
Thank
island. I
God.
live with them. And for me to spread the gospel is much easier, because I'm accepted as a villager now and not Sheher ke Babu, coming to teach. So I am there and I catch them any point of time and do it. And I'm so blessed. I'm so blessed because every time I take a step, I see Mother Teresa in front of me, smiling and pointing out, what to do in her own immaculate way. That's the, persona that I carry forward and do my work. And I would like to hear all of y'all talk, so that I also learn from y'all and carry that back into Sundarban, because we are landlocked. 142 rivers, 108 islands, 58 inhabited. I live in one of them. Thank you so
Thank
much.
you. Thank you. Thank you for that, Arup. That's truly, I mean, these could have been like your golden years of sitting back in a, sitting in your veranda, enjoying the sun and a nice cup of chai. And yet you're probably working harder, as hard, if not harder than any of us that might be, completely different age groups. Really an inspiring story there. We'll come back to that. Prateek, I wanted to ask you about your health. Your encounter with TB has been quite recent. Tell me how brain TB affected your everyday health, and tell us about that story and how you began to recover physically and mentally from something as horrific as that.
So actually, I think that I am a bit lucky that I had brain TB and not a pulmonary TB, because, like Arup sir said, that he had to be thrown out of his house because nobody was accepting him in the society. So at least my disease was not contagious. So there was a lot of family support, a lot of friend support. Everybody was around me. So that was one thing which I was lucky about. Second thing, yes, brain TB sounds horrific. So when my doctor first told me, so I was in the hospital for 7 days, and on the last day, I was told that I was suffering from brain TB. Otherwise, I was told that I had typhoid. So actually, it was a long story back then. Then, yes, the post TB medications. I mean, the medications during TB. I lost around 15 kgs in a month. So I was 64 when I joined college, and when I started having those symptoms, and then finally when I was discharged from the hospital, I had around 50 kg of weight. So it was so weak that I had to, even to climb 2 3 stairs, I had to take support from my family. And then the entire day felt nauseating. I was like, I didn't want to eat anything. It was just the medicines that I had to take, and that was it, because the medicine was my lifeline. A day
Yes.
of medicine missed, so was something that I never missed, and only to eat that medicine I had to take some food. Otherwise, I was not willing to take even a glass of water. So that is one thing about that happened during the treatment. Apart from
Mhm.
that, yes, I think after 3-4 months, life went back to normal for me at least. So I didn't have to face any physical problems as such. So I joined a company as an intern. So I just, it was just a mental stress that was building up, that what is this brain TB and what could go wrong about it. So just to
Mhm.
avoid myself from thinking all of these things, I included myself into various activities. Like I just wanted to get out of my home and do something and not just take a rest, because see, so I had another accident within two months. So I got discharged and I had an accident, so that delayed my freedom from my home. So I was again confined to my bed for 1 more month. So that was
Mhm.
something very strange at that time.
But of all the fun things that you could do once you sort of recovered and went back to college, what
Yeah.
made you decide to give time to like fellow to be an SATB fellow and to give back to people that have that are still struggling with this disease?
So actually, COVID never allowed me to go back to my college. So it is just again work studying from home only. But yeah, so joining ACTB was a conscious decision. So the only thing that I lacked here was knowledge about TB. So there were few
Yes.
things that I thought that if my family member or somebody who I could trust would have told me about that TB is not so deadly. I mean, it is deadly, of course, but if proper medications were taken, then it is not as deadly as it sounds to be. So that was something which was lacking. So I wanted to join ACTB and spread this message. Like, right, this is my first activity with ACTB that I'm doing right now. So this is something because of which I joined ACTB, and just spreading knowledge that TB is not as deadly as it sounds to be if taken proper care and medications.
Wonderful, wonderful. Thank you for that. We're so happy to have you as one of us, and we hope many more will join us after this summit as well. Over to you, Ritu. Tell me, who was, and you mentioned your family and friends were a great support system, but did you know any other survivors? Did you know anybody that had been through TB? Had you had conversations about TB during your own treatment?
Yeah, I spoke to a couple of them, Sandhya, but I met those people quite late in my journey, and I think that was one of the basic challenges that I faced. That there is no peer support network group that was so visible in the mainstream media that I could reach out to survivors directly. So I think it was through Google search that I came to know about SATV, and as I
Mhm.
spoke in the panel discussion also, that's where when I started reading stories of people, those people became a benchmark for me. I was like, if these people can recover and have a wonderful life post TB, I can also be one of them. So yeah, I mean, it was initially a challenge, but as I started researching more, reading more about, I got in touch with a lot of TB survivors, and I also got in touch with a lot of independent bloggers who had written about their journey on Instagram posts or on their own personal blog. So yeah, I did reach out to a couple of people, but I really feel that instead of being only a pull or an effort from the patient side, there has to be also a push from the high level. At the high level itself, you need to have a proper network of communities or peer support counselor groups. Maybe at the dot
Yes.
center, maybe a separate facility near any TB treatment center, where people can be counseled and told that, okay, yes, TB is challenging, but as Pratik said, but if you take medicines on time, you can have a life maybe way better than you were having pre-TB.
Absolutely. So this is something that we do as well. We do get people, survivors, to come in from different communities, and we help them overcome their hesitancy to speak, or that feeling that I'm not educated. So how can I be a force for change in my community? How can I be a support in my community? We do offer these trainings, and we empower them to become that source of strength for their community and to go into their community health systems. And but yes, we definitely need a lot more of that. Nobody can understand the TB survivor, a TB patient's pain like a survivor, and there's so many of us. So there's no reason. And I think all of us, one of the takeaways is that all of us we're doing so much, but we managed to give a little bit of time. I feel like what we've got back, both just from the joy of giving the support that however, right, each of us gives our time and our effort in the way that we can, and what we get back in return is just such a sense of abundance. And I think Arup is a fine case in point of like no reason for him to be spending and dedicating his whole life like this, but there is clearly a payback that you get as well. So, and this will also help transcend. A lot of us as survivors, we hesitate to speak, especially like this, or when we represent in front of the government or in front of authorities. But we learn, and when we align to a larger cause, it also helps us transcend our personal fears, get the courage to speak, and this actually helps us. Like you said, Ritu, it actually makes life so much better. We improve in so many other ways, and this leaks into every other aspect of our life as well, right? I never thought that we'd all be standing one day and speaking before government authorities and here like this at a conference. So wonderful sharing there. Kerry, let's talk about some very practical aspects. Taking medication, we all know that. I don't know how many tablets, medication you were on, but what were the sort of hacks that you developed to stay on track and as Prateek said that, we all know that we should be staying well nourished during TB treatment, but we don't have appetite. We're nauseous all the time, can barely drink water. Tell us how you managed to stay on track as far as keeping medication and nutrition on point.
Yeah, that's a very nice question, actually. When I was diagnosed with TB, my doctor, the one who said that, okay, you are TB patient, he made it very clear. If you miss one medicine, your treatment will fall apart. And I was like, oh my God. And I made it a point that I never missed. And yeah, for me, it was luckily my dad. He made it a point to give medicine on my hand. Like in morning he used to give, and then he used to call me back. Did you have your medicine? You had your medicine. He used to ask me. And this is how I used to keep track of my medicine. And my doctor made it very clear. If you miss any medicine, you will be stuck here. And the other thing is, what was the other question? I forgot.
How you looked after your food and your nutrition, because you have nausea and
yeah, exactly. That was really scary. Anything that you eat, you feel like vomiting. Anything you eat, you don't want to eat, but you have to eat it. So idli and dosa were my favorite. Whenever I used to have idli and dosa, nothing used to happen to me. Means I used to feel a little bit uneasy, but not like the other things when we eat. I don't know why, but this was the case with me.
Mm-hmm. I think the key is to find what you're able to tolerate and try and look at, trying to get as wide a variety as you can within the limits of what you can actually hold down, right? Because sometimes the challenge is just keeping it all down and not puking several times a day. One way to think of food I've learned over time is also to just think of it as literally, as one of the doctors in an earlier panel said, as medicine. Food is very much medicine. It's not.
I take it as medicine, right?
Absolutely. It's our fuel, it's our medicine, it's what's going to keep our body, our brains, our emotions healthy. And so sometimes we just have to send it down the hatch.
Yeah, what we say is we have to take food for the stomach and not for your taste. So that I strictly follow.
Completely, right? All of the sort of emotional attachments to food and stuff. Rather than that, if we just think about healthy, nutritious, just regular sabzi, dal, roti, chawal, and as wide a variety as we can is really the key to nutrition. It's heartbreaking that there are many that cannot afford it. But I think another problem that we have, especially in urban areas, is poor quality nutrition, right? We're all eating snack food from QSRs. People, I see like the guy who comes to repair things in my house, all his meals are had on the road, and he's just eating refined carbs, deep fried foods, and so much fat and so little nutrition. So very powerful point you made there, Kiri.
Thank you.
I'm going to raise a topic that could be a little uncomfortable, so I'll open this to anybody that is willing to answer this on the panel. One of the aspects with medication with TB is I don't know how anybody had their experience with sexual desire. Did anybody feel like a drop of sexual desire? Did anyone struggle on any points relating to that? Did you have a fear of infecting your partner? Did you have a fear that you will never find a partner? I'll open it to all my panelists if anybody would like to take that question.
Yeah, may I?
Please, Arup.
Yeah. See, I was very lucky in the sense that when I had TB, I was told I'll die in 6 months. So that was the first thing, and I actually lived till in the hospital for 2 years. So medication, food, and all that were taken care of there. And obviously, as I was growing up as a teenager, the desires are always there. Okay, that didn't stop. And I was fortunate that as soon as I came out, my wife was waiting to marry me. So at the age of 20, we got married, and I told her that look, we should not have children. She said, let's have the child and leave the rest to God. So we had two beautiful children. Sex was never a problem. I was working, and neither she was scared about it. And this is something where we discussed this at length in many places, and we found that it was a huge taboo, and people were very scared as to what was happening. And when both the children, this thing, were born, they were absolutely clean. There was no sickness at all. It is just that when I had my second relapse in 1976, for whatever reasons, both the children had a little bit of it, but 21 days of good medicines and good treatment got them out. They're both clean now. But I'm with you on this. I think it's a normal life. And that's something that I try to advocate throughout. And I've seen that happen with Mother Teresa because I worked extensively with her, going from point to point. We would tell them lead a normal life. Lots of taboos, and I'm sure you're going to question us on that. So I'll leave that aside. But I think we should take life as it comes and be absolutely normal because it is, if I take all my own precautions, it's difficult that I will transfer it elsewhere. That's the myth that a lot of us carry with us, and especially women. I was very lucky that Dalia, my wife, never had any problems on this.
Lovely. Thank you, Arup. Is there anybody else who'd like to chip in with their experience or their thoughts? I know for a fact that I was worried about, I had 2 young kids as well, and I was worried, but we didn't even end up getting them tested because, as the doctors have mentioned, right, that most of us, like 40% of us, have latent TB and we're exposed, but it will manifest only if, your immunity drops or, there's certain comorbidities. But definitely during the entire year of my treatment, there was zero, like my sexual urges were nil because the exhaustion and the nausea, right? But yet, you feel like, oh my God, do I have to perform because am I being a bad wife? And these questions do arise. And I think it's important for us to be able to have open discussions. It's not always easy in traditional Indian societies, but I think that's where if care workers come into the house and sit down with the rest of the family and they initiate these conversations, I think, again, we'll surprise ourselves. And if it's women who are suffering from TB, I think that men could actually be very, very understanding. And of course, if the males in the family are the ones suffering, just the compassion of everybody else around to know that, and even for caregivers, it's really tiring, it's really exhausting, and it's emotionally very stressful for caregivers as well. So to have all of these conversations, would anybody like to chip in on what it was like for your family members or those looking after you? I can only imagine how stressful that must have been for your family, your parents, your loved ones. Did they have fears for you? Did they express anything?
Yeah. Yeah, actually, parents had that fear. Parents had that fear, and you know, we all have the tendency of like hiding things. I don't know why this is something I can't do it. We all have it's not about we all have tendency to hide things, and this is the like this thing to be hidden. It's like implied, you know. So parents had that fear. I agree. Like I cannot understand how parents feel, but they had that fear that now she has TB, so we have to make it a point that others should not know it, and they felt that why should anybody know it? Like we are there to take care. Why should anybody know? But yes, my family and my extended means my dad and his brothers knew, and his brother's family also knew. This many people knew, but beyond that, nobody knew I had TB. In fact, my TB was kind. Even my doctor, when he saw me for the first and second line treatment, he was like, three of us went, and he was like, "Who is the patient?" He couldn't make out who is the patient, and he's like, "Who is the patient?" So in my case, only my near ones knew, but yes, my family was afraid to let others know beyond my extended family, beyond my father's brothers or my mom. No, my father's brothers and their family. Beyond that, nobody knew I had TB till I joined the Survivor Against TB organization. When they came to know that, okay, you had TB, we couldn't find out. It was like that. So yes,
and again,
yeah.
Sorry, go ahead. Please finish. Yes.
Yeah, that is fear parents, I think most of the parents have. And it's like they have and they will be having, I feel that. But they should not have it, because there's the point of hiding things, because we are like conditioned to hide things. It's not only about this. Many things we keep hiding. If we make some good recipe, we'll also hide that. We'll not share the recipe with people. So this happens.
So it does take courage. And like I said, it's the fear, right? For a lot of our survivors that did come out and join SATB, it was this, right? That suddenly my neighbors will find out, all the people I hid it from. But more and more we hear stories of how so much of that fear was unfounded. Yes, the stigma still does exist. Yes, there will be those people who will say, now, shadi nahi karne, all of that. But those are, I mean, I'm not saying they're outliers, but I'm saying very often that the fear is what holds us back. And we lose out on this opportunity to create these genuine connects. I will also say that we, SATB, we are a family to each other as well right now. We also have a WhatsApp group, which is constantly buzzing. And just to know that you're part of a conversation, there are people you can lean on. In fact, I'll say my SATB fellows, they keep me up. They want to play Antakshari all the time. But literally just having this family to be with and have these conversations with, really, it's so empowering and such a solace. Prateek, you were going to add something as well. Let's hear from you.
Yeah, I mean, kind of on the same line. So, like at my place, it was not something to hide. But again, any disease is not. It is again not something to like tell to the entire world that yes, I'm having this. So whatever fears they were, it was just about that. Let's not openly say. Otherwise, in fact, there's two strange incidents that happened. So when my parents, like somebody asked about my health, when my parents told that yes, he's suffering from TB. So at that moment of time, my mother got to know that her best friend also suffered from TB. So this was something which I found out that if at all she was aware of this problem earlier, then possibly she would have contacted her to how about to find a good doctor, or maybe how to go about the treatment and any precautions that needs to be taken. So I think people need to be vocal about it, so that the community knows that yes, there are people who can survive, and there is nothing to be fearful about it. So I think this is the incident that happened at my place.
So careful, probably yes. Fearful, probably less so, right? And you mentioned that your college authorities were very understanding as well, and they allowed you to take that year off and continue after as well, right? So, and the other thing that like a survivors group can do is we often will help to take up somebody's case, right? Something that you cannot address on your own. This is where the advocacy really helps. And something as simple as helping you get medication. I say SATB, we've helped people get medication across to remote areas or in places where stocks were low. So just you need to put yourself out there and say that, listen, I need help, and I just need somebody to talk to, and we are there for you, and you can hopefully be there for the next person, and not have them suffer alone. I wanted to ask again to anybody, does anybody have any after effects after the medication? Are there any lingering effects on anybody's health? I know some of us feel healthier than before, but anybody has any? I know for a fact that my lungs will probably always be a little scarred, but it was my personal challenge to build my lung capacity up. Happy to say it's better than it was before TB. So I wear my scar with pride. But do we have anything else?
Yeah.
Arup. Yes, Arup.
Yeah, I went back into active sports after I contacted tuberculosis. And I was a professional footballer, cricketer, hockey player in Kolkata. I did that. But the second time after I had the relapse, my lungs collapsed. Okay, during the two bouts of sickness, the right lung totally went away, and whatever little was on the left side. COPD is something. First, I got asthma, and and it slowly started getting worse. So as I started aging, like right now, COPD is something that I'm living with for the last 8 years, but it's not stopping me from working. I'm so fortunate because there was a time when I just wanted to end my life. It was me and the balcony 8 years ago. I was doing very well, and there was a lot of money for the family. My son at that time was about 42, my daughter 41, and I said, okay, let me hop off. And I remember I had tweeted to Amitabh Bachchan because I remember he's a TB survivor and he's a COVID patient. And he wrote back, live with it. That's the only answer. I do. That's it. That was that one message out of thousands, probably to the world in Twitter to help. And it stopped me. It stopped me. And then I started doing a lot of research, understanding who are the others that have got this. And I found that most of the people who's who in the world of sports or in the glamour profession are all having it, and they're carrying on with life. That's the time in 2013 I realized that Notun Jivon is something I need to do. And I had opened out a page even without knowing why. And I put Notun Jivon. And here I am today working in the field. Sundarban is 3 hours from here on the streets of Kolkata. And I don't miss my beat. I have to go out. I have to go in, end of story, even if I have to wear an oxygen mask. And I am not scared. I was at one point of time. There is no fear. But I would like to bring in a small point here. There are still people, and when I go to their home, I can see the plates getting changed. And that hurts. So the fear is with them. It's not with me. And I've stopped going to people's homes because I don't like plates to be switched, or a tumbler, stainless steel coming instead of let's say a glass that way. So that's the only thing. Otherwise, absolutely there with you. But yes, I did have a lot of problems in my lungs.
That's a very powerful story you shared there, Arup. I think a key point, and some of us have trained as suicide first responders as well. I think a key point for this sort of protracted, treatment time and recovery time with TB is that very often, and correct me if this was, tell me if this was your experience, it's not so much that we want our life to end, it's that we want the pain to end. We want to see light at the end of the day. And so much of that us standing on that balcony, and I've been there as well, not during TB, but in another point in my life. But that point where you're standing at the balcony, it's not really us saying that, listen, I just want to, transcend this world or whatever. It's really us saying that we don't want to be suffering this pain anymore. We can't, we simply can't suffer this pain anymore. And we would love for somebody to just reach out and say, hey, you're not alone, and that you can get through this. And when we hold hands, and again, from a behaviorism point of view, from a scientific perspective, just having somebody by your side will make the mountain in front of you seem a little bit more achievable, the path less steep. which is another reason why nobody should have to go through this alone. And we all know that you can be in the most crowded of cities and feel absolutely alone, feel completely hopeless, and wake up every day thinking that I really should have been feeling better by now, and it's not happening. There was somebody that was in treatment for 7 years. This is really a place where a community can help, and asking for help, and it's really our right to be able to receive the support from whichever community or group that this might be. Thank you, Arup. That was such a wonderful point, and so powerful as well. Let's talk about life going on. Oh, let's talk about our relationship with our medical professionals. How comfortable did everybody feel in terms of asking questions? I mean, I think everybody on this panel is in a different point in their life. As students, Arup was just a 16-year-old, but like, did you feel like you were getting the answers to the questions? I know a lot of us didn't know about our side effects, but just to know, like, are we going to make it? Who was the one in your lives that would answer all these questions, or did anybody? Let's just go around the group, and this time we'll start with Ritu, because you've been quiet for a while. Ritu, go ahead.
Yeah, Sandhya. I mean, I had a good relationship with my healthcare professional, but still, there were many questions that were always unanswered. I was never told, when this phase is going to end. Okay, first I thought that I'll take TB medication for 6 months. But after 6 months also, when I got the test done, I mean, the report is still saying that I'm still having TB. And I was like, okay, if it's not ending after 6 months, then next what? Then I was told once more. I got the test again, I'm still having TB. And then I was like, okay, when it is going to end, can you please give me a right answer and be please honest towards me?
Ritu, come back to us, I'm sure. We'll give her a minute. Yes, Prateek, tell us about your experience. Did you have your questions answered?
No, I suppose. So my relationship with my HCP was somewhat like, he was too frank and too clear with the answer. So like the day I was told that I had TB. So he said medications would take 1 year. You have to you have to take your medicine every day. Otherwise the treatment would fall apart. And that was it. So nothing is apart from that. And any precautions, so whenever I tried to ask about any precautions, so he said that no precautions at all, you live a normal life, no precautions. So he never told me about any side effects, anything about it. So, and that was also the reason that I also felt uncomfortable asking more about it, because I felt that possibly there is no side effects, because he isn't telling himself. But then when I researched up online, I found out from my sister that I like first contacted SCTB through Ritu. So my sister was a junior of Ritu's undergraduate college. So I talked to her. Then she told me about SCTB. I went ahead on the SCTB website. Then I actually found that there are so many side effects, some of which were a tick box that I was facing, and I was never told about it. So the nausea. So whenever I tried to ask about that, when will this nausea end? He said that it will end someday. No problem. It will end. But there was no clear answer from his side. So it was a strange, and that is something which I found was lacking. And that was something which I wanted to do through ACTB, to spread awareness about this. And yeah, I think the doctors need to be more compassionate with the patients. Sometimes very brief answers can also be harmful. You can explain you can explain the patient. So I think that is something.
If not the doctor, an ancillary healthcare worker, right? I was just mentioning yesterday that our doctors are so overworked, but certainly this is such an integral part of us having to deal with the disease. So it's almost a non-negotiable for us. Kairi, your experience
with the practitioners, my doctor.
Yes, and just understanding, all the aspects of the disease and what you needed to do.
Oh, my doctor, my first line treatment, when the doctor was like, I don't know, I trusted him completely. I never thought that any treatment fails, I thought only you fail in exams. Like treatment failure was something very new concept for me. I never thought that doctors will fail treatment. And he was like, yeah, what to say? He never told me. I forget about side effects. His way of giving medication was also, if I tell you, means now we will laugh, but then like we are completely unaware. Um, he used to give me one medicine and other medicine I had to break into half and then eat it. I don't know what kind of dosage he was giving and all this kind of crap. And secondly, whenever I asked him about, I never asked any question because treatment failure concept, I was like naive to it. I didn't knew that treatment failure happens. But after 10 months of medication, when I developed this, what it is called, abscess on my right or left, yeah, chest wall. I thought it's an abscess. I didn't feel it's something wrong. Then he said that okay, we'll give you more medication, and then also he didn't say that he failed treatment. And this is how it went. Finally, I was relieved when he transferred my case to my next doctor, and I was relieved. So this was my experience with my first line doctor. It was like pathetic.
So I think, I mean, even then, these are just about medication. So explaining side effects is
no,
non-existent.
They don't do.
And I think there's so many other aspects, like answering our questions about what should we be eating. Somebody should be telling us, just reduce the stress in your life, or I mean, those aspects.
This was I didn't even ask to. No, actually, when I didn't ask, and he didn't say, it was like that. It's not. I didn't even ask him what should I eat. Nothing like that. I did, and he didn't say. He just used to diagnose me and.
Most of us that go there, we're so sick, it won't even strike us to ask, right? But that these are some of the conversations that have come up during the TB summit, that it's up to the healthcare workers or the healthcare system at least to be able to inform us of, because all of these is part of the care, right? Which includes even how we're living our lives on a day-to-day basis, being able to ask for leave from our employers so that we can get the rest that we need for our body to rehabilitate, to get leave with pay. These are all important aspects which perhaps a doctor will not have the time or the bandwidth for, but certainly the healthcare system needs to provide. Because I know, for example, of so many people that have had to go back, their house help, for example. So not only are they having to work with TB, but they're also putting their employers at risk because they don't want to tell them about it. But then what choice did they have? Arup, I'm going to pivot the question a little bit for you, because I wanted to ask you about your experience at this. You mentioned that you were in a sanatorium and that you were two of the 16 people that actually survived and came out of this alive. What was your mental state in the time that you were in the sanatorium? If you could just share that with us a little bit.
At the age of 16, there were 16 of us in that room. There were two kids, myself, I was the youngest, and there was another one who was a year older than me. And every time we heard the oxygen cylinder opening, we knew that someone is going to go. And trust me, I relived life every day. Every minute, I had to relive it. That I am next, I'm next, I'm next. And that fear of dying finished the day I walked off. And that's the last time I looked at death, because I came out clean. I have goose pimples just remembering you say it. And I'm so happy that you asked me to say it. The only problem is that no one is concerned about tuberculosis. Like the way polio, we got rid of polio. And I keep writing to Mr. Bachchan that if he can take this cause, because the ASHA workers and the Anganwadi workers, they are not trained to propagate and explain. Even today, if I want to go and get medicine, I go to a general practitioner and I want medicine. I'm shifted out even today to a corner to some department called TB. And everyone looks at me as an outcast. Even today, today's 2010, and it happens, and this is across India. This is across India. It doesn't belong to a state. And I'm so happy this summit, because I've been listening from yesterday and today. I feel so proud to be associated here. And, offline, if we can take this further back into my village, and that's something that I am discussing loud. It's very prevalent, ma'am, because the fear of dying is very strong for a TB patient, because that's the way it's told. कि आप बचोगे नहीं, आप 6 महीने जियोगे. And that even today, and I've seen doctors. I've gone there just like that, and I've heard doctors say, क्या फायदा, आप तो जियोगे नहीं, आप तो दवाई नहीं खाओगे, and things like that. So this is something which is very serious, and I hope offline also, all of you, Sandhya, if you all could take it up in various forums, I would definitely advocate.
Absolutely. Thank you, Arup. This reminds me of a quote by Helen Keller, and perhaps a good note for us to end on. She said that although the world is full of suffering, it is also full of the overcoming of it. So for every person that gave you a steel plate, or relegated you to a corner, Arup, you're also loved by every one of those children whose lives you've touched, every one of their families as well. So I think if we choose to build our community, if we choose the people that we want to surround ourselves with, and if we also lean on each other while we petition for change at a larger level, at a societal level, changing mindsets, ending the stigma, and I'm confident that, again, I mentioned this yesterday, I think India, we can leapfrog, and we don't have to wait for a new generation of woke individuals. I do believe that through technology, through voices such as ours, we can change mindsets. And very often, mindsets of others are also because of fear and ignorance, not because of malice or any kind of inherent hatred. People, I do believe, are inherently good, and it's just lack of understanding, ignorance, and fear that makes them behave in a way that it's really just them trying to protect themselves or their own. Speaking of stigma, I just wanted to bring to everybody's notice as well that SATB, we're releasing a movie. It's called Stigma Around TB, A Silent Note. And the voiceover for this movie has been done by the esteemed actor Shri Anup Soni. So that is going to be released shortly. I think that could be a powerful message as well. And I hope it's one that reaches smaller towns and villages as well, as Dr. Mehta yesterday and Arup just mentioned. The story just 50 kilometers outside of a big city can be so different in terms of stigma and in terms of the kind of isolation that a patient could face and just the fear around it, right? So we need stories like this, and I hope this movie will play a significant role. I do believe that brings us to the end of this session. I cannot thank each of you enough for sharing so openly, being so vulnerable and inspiring and giving hope to so many. Thank you so much, Arup. Thank you, Kayuri. Thank you, Ritu. Thank you, Prateek. You guys have been so brave, so positive and optimistic. And to everybody listening here today, do know that Survivors Against TB is a group. We're a community of survivors for other people. We're here for you. We're here for the communities. There are several other communities working as well in this space. Do find communities like ours and do become a part of it. Don't let fear stop you. Don't suffer this disease in isolation and with loneliness. You will come through this, and you don't have to do it alone. Thank you all, and thank you, Pi Consulting. Thank you, Indian Express. On behalf of SATB and everybody in the audience today, thank you so much. Goodbye, everyone.
Goodbye. God bless.
Thank you.
Thank you, Sandhya.
Thank you.
What do you think of people fighting TB? Or people who have survived TB? Do you think they are different from you? How different? Contagious to be avoided. But why? Do you know that every type of TB is not contagious? And a few days after medication, TB patients can't infect anyone. Then why discriminate? Anyone can get TB, even you. Come on, India. Let's fight TB, not the people it affects.
Hello, my name is Salman Keshavji, and I'm Professor of Global Health and Social Medicine at Harvard Medical School and Director of the Center for Global Health Delivery. I want to thank the organizers for inviting me to participate in this summit, and today I'm going to talk to you about how to stop tuberculosis in India. We all know the global stats for TB, so I'm not going to go through them other than to say we are finding ourselves in a terrible situation where 4,000 people are dying every day from a disease that's been treatable for more than 70 years. And of course, for years, a lot of effort has gone into reducing rates of TB. But if we look at what we've achieved, it's worrisome. Drug-sensitive TB rates have declined by 1.3% per year between 2006 and 2016. MDR TB declined 2.1% during that same period. But XDR TB actually increased by about 7.9% per annum. And in addition to the situation that we're expecting after COVID with tuberculosis, we are also facing rising rates of diabetes, which are a concern for the TB elimination agenda because they're a big driver of TB. And if you look at South and East Asia, the number of diabetics is expected to increase by 74% in the region by 2045. So we're left asking ourselves, is there a way to reduce rates of TB faster? And the answer is yes. TB elimination can be sped up and even achieved using the search, treat, prevent epidemic control strategy that has existed since the early 1960s. So the search part is fairly obvious. We have to search for people with TB. We have to search actively for people with TB. So for the search to be done right, it has to be active case finding using a sensitive diagnostic. Now, since the early 20th century, that diagnostic has been the X-ray. It was a critical tool for finding active cases and stopping the transmission of TB. It was first used in Edinburgh in Scotland in the early 20th century, and it became the norm. Here you see an X-ray van in the US state of Florida. It was used for case finding in New York. It was used all over the US and Europe and Canada and Australia and New Zealand. And it not only contributed to finding new cases, but to decreasing mortality because of early case detection. It was highly sensitive. And of course, today we have not only X-ray to do mass screening, but we even have a confirmatory test in the sense of we have genetic tests. And we can see here in a model published in The Lancet in 2015, what would happen if you did active and regular case finding in South Africa, China, and India. Drops in rates of tuberculosis and drops in TB mortality. The other intervention, of course, is to treat TB disease correctly. And by treatment, I'm not going to go into it very much for reasons of time, but early treatment with the correct medicines in a multi-drug regimen stops transmission of both drug-sensitive and drug-resistant strains of TB rapidly. And there are a lot of data to support this. The third thing is to prevent. You have to prevent TB infection from becoming active disease. Now, that means treating TB infection that has not yet progressed to clinically apparent disease. And that is an essential part of stopping TB transmission. So how did we find this out? Well, George Comstock and colleagues from the US Public Health Service working in Alaska found that after they had screened people using active case finding and they had treated all forms of disease, they still saw TB in communities, and they saw children being infected in their early years of life. And so what they did is they started treating what they assumed was TB infection, people who were infected that hadn't yet progressed to disease. And they gave them isoniazid prophylaxis, and lo and behold, with the combination of active case finding, treatment of all forms of diseases, and treatment of TB infection, they were able to bring down transmission in the household and community, and they used the annual risk of TB infection in children as a marker of this. They were able to bring that down to 0. And since then, there have been 23 randomized controlled trials in a variety of populations that have shown a protective effect of preventive therapy. And for non-HIV infected risk groups, this has been an enduring protection that continues over time. And it's clear that this approach is a very good way to stop people who are infected from progressing to having TB. Now, people are worried about drug resistance if you do this, but if you screen people properly using a sensitive diagnostic like X-ray, it's been found that there's no significant increase in the risk of developing drug-resistant TB. So there's no significant risk in developing drug-resistant TB. And of course, it makes sense to treat people with TB infection before they get disease, because if we look at who has disease, the 6 to 7 million people that we find are actually a very small proportion of all the people who are infected. And we have to ask ourselves, how many people who are infected will get TB in the near future? And the answer to that question is known. About 8 to 10% of contacts will get TB during the first 2 years after exposure to an individual with active disease. So when we find a case, we have to screen their contacts, make sure they don't have TB, see if they're infected, and then give them treatment. And that means that globally, around 20 to 30 million contacts a year should be receiving treatment. And this is in keeping in what the UN high-level goals are for tuberculosis. So we know how to stop TB, and a lot of these principles were actually discovered in India at the British Medical Research site in Madras, now the National Institute for TB Research. So we have to search actively for newly infected people among close contacts using a sensitive test like X-ray. We need to start the most effective multi-drug therapy quickly, so the correct and most effective therapy for people that can be given over the shortest period of time. We have to ensure adherence with supports. We have to treat all infected contacts that don't yet have the disease so they don't progress to it. And of course, we have to ensure proper infection control. And what can search, treat, prevent, achieve? Well, it can move us faster towards the elimination phase. And we see this in a lot of settings. This is what happened in Alaska. The rates dropped markedly over almost a 10-year period, and the rates stayed low. In New York City, when they had an outbreak of TB, 1/5 of which was MDR TB, they did community-based active case finding, treatment of all forms of TB, and treatment of TB infection, and sure enough, the rates dropped. Same thing happened in Russia, in Tomsk. They had a comprehensive strategy, and the rates dropped by more than 50%. And that's exactly what has been modeled by our colleagues at the World Health Organization, that if we were to use the current tools properly, we would see a drop. Now, what do you expect to find if you do this? Well, you'll see a peak, because active case finding, you actually find people, right? More people than come passively. But if you do active case finding plus treatment of all forms of TB plus treatment of TB infection, you will drive down case rates by stopping transmission and preventing TB infection progressing to disease. And people always ask about cost. Well, right now we spend a fixed amount of money. That's the amount in red. It costs money, but it doesn't seem to bend the curve. If you put in a comprehensive approach, which is what's represented by the blue line, the initial investment is a little bit higher, but then it drives down rates and it drives down costs over a 10-year period. So you can see that your net costs ultimately are less. And not only that, we're always talking about health system strengthening. So if you can create a community-based care delivery platform for TB, if you can extend the clinic into the communities where people live and work, then basically you have created a community-based care delivery platform for chronic diseases, right? You could be treating HIV, hepatitis C, diabetes, heart disease, mental illness, high blood pressure, etc. So for India, in short, we need to do search, treat, and prevent. We need to do more active case finding. It has started, of course, but using mobile screening units, it has to be expanded. Preventive therapy is only in place now for children under 6 years old and people living with HIV. So we have to urgently expand the treatment of TB infection in people who have been exposed and do not yet have the disease, who have not progressed to the disease. The WHO changed their policy in 2018, and the new strategic plan expands the use of isoniazid prophylactic therapy for contacts. This has to be expanded to everybody who are family contacts and close contacts. Let's remember, the United States has been doing this since 1962. So although rates in India have come down, the decline has been similar to the global decline, and we're declining at 1.5% per year, and we need to get to 10 to 15% per year to meet the goal. So adopting search, treat, and prevent will help India move towards TB elimination. Thank you very much.
Good morning, good afternoon, everybody. And I'm really honored, and I would like to thank you very much for inviting me to share a few words with all of you. I am sorry that the background is about the clock ticking, and I didn't manage very well the TB survivors background, but I think even if we don't have a background with TB survivors, I can promise you that the TB survivors, you are all in my heart. It's an honor to speak here. It's also amazing to have a summit organized by the TB survivors looking at reimagining TB care. As you know very well, reimagining TB care is one of the topics that we at Stop TB Partnership looked at for the last 2 years. And I think even much more as all of us after COVID, because if there are many lessons that I think we can take from the COVID experience, and over years there will be probably articles and books written of what we learned from the entire COVID-19 pandemic. But one point that I think it made it very clear, the entire story with the COVID, is the fact that we need to have the services coming absolutely closer to people that need them. And this is what should be the importance of reimagining TB care, bringing the healthcare services closer to the communities and closer to the people that need them, and making it accessible to everyone, starting and including, obviously, those with most vulnerabilities. And I am very happy also that this summit is taking place, obviously, in India, because actually in India, there are a lot of things happening nowadays in addressing, in a way, tailoring the health services to basically continue delivering services for COVID, but very important, maintaining and even increasing services for other diseases, and the one that we are obviously all interested in is tuberculosis. So I am a strong believer for many years, but after and during this pandemic, I'm convinced that India should play a leadership role in the global arena, in the regional arena, in the way in which you can craft what you have to really deliver much more. And the points that I want to make about what should be done in order to rethink some of the work that we do, I think we have 4 pieces. One is we need the data. Having live data, the way that are now available for COVID, and having the same type of data for tuberculosis live, that can serve our programs and, ensure that we can change and adjust as needed based on the evidence. It's extremely important. The only country in the world having this type of data globally, at global level, the only country is India. And congratulations about that. It's absolutely important, and we should see other countries looking at the leadership that India is having on this aspect. The second is the importance of community health workers, volunteers, networks of civil society, networks of TB survivors, as engaged in the service provision for people with TB and for people with COVID. We should not reach out to all these amazing networks just to be part of some dialogue or some thinking. They should be part and at the center of it, of the entire cycle, from thinking of a program, delivering, monitoring, and evaluating it. And we should remember all the time that if we want to reach individuals and people that are suffering and are being affected by TB, by COVID, you need to really go at the community level. There is nobody else that can come door to door and get the same level of engagement and transparency and dialogue that you get by engaging community health workers, the volunteer networks, survivors, and other type of civil society networks, faith-based organization, and so on, with the condition that really they need to be properly funded, properly equipped with PPE and with all the other measures. The third point that I want to make is related to what is needed in this time is considering and having this bilateral testing for TB and COVID. Once we do contact tracing, and in TB, contact tracing and active case finding is what for many years we were speaking about. Once we have an opportunity to reach individuals in the communities, it's a missed one if we are not able to discuss about both diseases, if we are not able, if assumptions are there to treat, to diagnose, to test, to diagnose, and potentially to treat both diseases. And when speaking about treating and linking to the point before, the networks of communities and survivors are amazing TB supporters or providers of information that we fight stigma and we fight assumptions and we fight preconceptions on the vaccination, on the diagnosis, on the test, and demystifying different myths that can be in the communities. So bilateral testing, to go back to the point that I was making, is extremely important because we need to be smart. Resources and human resources as well as financial resources are never enough. So let's use what we create for one disease to really support the other one. And I know that especially in Asia, a lot of the TB platforms are used or continue to be used for diagnosing and tracing potential contacts for people with COVID. The fourth point that is extremely important in addressing is the use of digital technology. We are moving, as we see, at a rapid speed in increasing the role of artificial intelligence and digital technology in the TB programs. And we need to reinforce that, but we need to be mindful that it's digital technology that should be accessible to everyone, including the most marginalized. It's not enough to speak about let's focus on digital technology if the right people don't have access to it. And when I say the right people, I obviously refer to everyone that is in need and everyone irrespective of gender, location, religion, and whatever other vulnerabilities exist. So these are my points about why COVID learned us and what learned us to do, why I think India is an amazing leader in the region that we have to look at, and why I think there are 4 or 5 points that we really need to follow up if we really want to change and come closer to people. I think you all had amazing discussions. I am sorry I took some of your time. I am pretty sure I didn't bring anything new. Maybe I tried to wrap it in one point. I just want to finish this. We are all here because we all believe that we can end TB. And I think we have our will, and I think it's in our power to really end TB. Times are learning us that we really need for that to be very flexible, to be ahead of the curve, and to be very big risk takers. And if we come with this and with a lot of will, we will be able to do it. So thank you very much for this meeting and giving me the opportunity to speak. And I wish you all the best. Thank you.
Hi everyone, this is Priya Dutt. I'm very happy to be part of this summit and thank you very much for giving me this opportunity and this platform. I have been a member of parliament for 2 terms and have represented the North Central District in Mumbai. I am also chairperson and trustee of the Nargis Dutt Foundation working in health and education. And most of all, I'm here to speak about my experience as a person who's gone through the rigors of tuberculosis treatment. I want to begin by talking a bit about my work as an ex-member of parliament in my area. North Central District comprises of a lot of slum pockets. We have nearly 50% slums. And while working there, and in my tenure as I was, visiting the areas, we found one slum which had very, very high cases of tuberculosis. And during that time, we decided, let's do medical camps there to assess the situation. We realized that people were completely unaware of their symptoms, unaware of what they need to do, what the treatment will entail, what the nutritional support they should have. We also realized that there was a lot of taboo and stigma attached to tuberculosis. I remember some parents coming to me crying and saying that our children are not getting admissions in the local schools because once they come to know they live in this area, they don't want to admit the children in the schools out of fear that they may be carriers. I realized the medical camps were just not enough. And what needed to be done was a lot more, especially creating the awareness. At that time, even though I was member of parliament, a well-educated girl, came from a very good background, I still didn't understand that TB could happen to anyone. TB is something which can happen to anyone. And I realized that only when I suffered through it. Everyone I asked felt TB was a poor man's disease. How can it happen to us? But this myth had to be broken. The first time I got to know that I had to be treated for tuberculosis, I didn't even know that tuberculosis could happen in any part of your body. The fear of getting TB and living with your family, being a carrier, and the fear of infecting others is huge. I got TB of the heart, and I was quite surprised with that. But the treatment I had to go through was rigorous. An entire year of toxic medication going into my system. I realized I was able to bear that because I had good nutrition. I took care of myself. I was aware as to what I needed to do. I went to doctors regularly, but realized there are thousands out there who don't even know what is happening to them, who are not even aware, are not even counseled. Therefore, I think it's so important to reimagine TB and change our approach towards it. I want to bring you to the point of the pandemic we all have faced. And the pandemic actually made us understand and realize that how lacking we were in our health systems. We realized how lacking we were in information dissemination. But there was a political will. The governments of all states took it upon themselves that they had to attack this. And the most important thing they did was to spread an awareness about COVID-19. Every person from living in the highest high-rise to living in the slum knew what COVID-19 entails, what its symptoms are, what you must do and what you mustn't do. This again brings us to a point saying that we are able to do the same thing with tuberculosis as well. One thing I cannot comprehend, that how can we allow people and their communities and their families to be devastated with a disease like tuberculosis, which is treatable and which is curable. We need to stand up and do something about it. There are a couple of things which I feel are extremely important. To begin with, is creating an awareness. Letting people know TB can happen to anyone, no matter who you are, no matter how rich or poor you are, it can happen to anyone. The treatment of TB is very rigorous, very toxic. We need to really ensure the kind of treatment that we impart, the duration becomes shorter, more tolerable for the people. Counseling is extremely necessary, especially for poor patients who do not have that facility with them for good nutrition, good homes, good air to breathe. When you go into slums, they live in conditions where there is no air, there is no light. They live in congestion. How do we really go about helping them? Today's summit, I think, brings a lot of things to light. And it's important that we sit and discuss. We create a political will so that what we have discussed here can actually happen. It is most important that information dissemination happens on a large scale where TB is concerned. We can fight TB, and together we can do that very successfully. Thank you so much for having me here on this summit and allowing me to express my views. Thank you so much.
Hi, my name is Dr. Saurabh Rane, and I'm an XDR TB survivor and also a fellow with Survivors Against TB. It's been an honor being a part of this forum. And for me, the purpose of this forum, or in my mind, the purpose of this forum as not just a TB survivor and a member of SATB, but as a representative of most of the patients that we talk to and cater to, is to help the world and help you understand how odds the system is with those who need it the most, right? Which is the end recipients, the patients, the communities that are affected by TB. And a system in which people don't have a say is just not for them. And this is something we know very, very well. So let me try to summarize it and put forward some key points about TB as a disease and what are our expectations as survivors, patients, and communities that are gravely affected by every move that the system makes. TB affected individuals come first, right? And if you don't understand their situation, their challenges, their needs, then the system is not responding to them, or it's not responding to the disease in any way. So there are a few challenges and a few solutions and a few ideas and how we reimagine the whole thing to make it more patient-centered is what we need to take away from this forum. So let me start throwing some light on challenges that I not only faced personally, but I do know that a lot of other patients also face. And the biggest one being misdiagnosis, the treatment, just the term of the treatment, right? How long the treatment is, the amount of side effects that patients have to face. And the whole thing is based on a social system that is not supportive in any way. Just think about all the stigma, all the hiding that patients have to do. If not the mental and physical trauma not being enough for them, it's also the lack of being able to connect with someone and share their pain, which really takes a toll on patients. Let's try to look at a few challenges that are more broader, on the broader level, right? I think access to verified and useful information. Most patients come to us and they want to know what exactly is this disease, how did we deal with it, where can they connect with other patients, how can they find inspiration, what tablets are correct to take and what not. It starts from these small issues and goes all the way around to help us get through treatment. The second is the right diagnosis at the right time. Just having someone know which pills they're supposed to take for how much duration and handhold them through the process is just as important. It's a right. Patients have a right to get their right treatment. And also having access to counselors and supporters. Everyone needs support. It could be a patient, it could be a survivor, it could be someone who needs advice on how to deal with the disease versus someone who knows what to do now that they're cured and if this disease is going to come back and haunt them. Two topics that are not really touched are those of the economic sort of ramifications of the disease on patients and also the mental breakdown caused by stigma. These are just a few challenges that I'm bringing on, which open up so many opportunities, also based on things that we've heard throughout this forum, right? So how do we deal with this? What do we do together? I think one is, let's just open up all communication channels, right? Helpline, text messages, social media. Let the system talk to the patient, let the patient talk to the system as much as they can. Second, let's invest in better drugs and diagnostics, right? Let us not make people wait and take their medicines for a longer time. Third, we keep on telling patients that, oh, you should take your medication, but we don't think about the effect that stockouts have on them. If you're going to ask someone to take medication and not provide them the right medication on time, it becomes very difficult. It's a mixed signal. And moreover, patients freak out because we've already instilled so much fear into them for missing their medication. Fourth, let's go and take the system to the patient rather than expecting the patient to come to the system again and again. We have to explore innovative ways of delivering service. And lastly, let's safeguard them. If someone's discriminating against them, let us have action points. Let us have trainings. Let us have awareness campaigns so that the society is more supportive and less monitoring. And I think to put this in a nutshell, let's make systems more patient-centered. Let's treat patients and communities and TB-affected individuals with empathy and dignity. And let's fight stigma and let's make this a system that supports patients, that is based on their needs. And I'm going to end this by saying what I always say, and I will keep saying, is we are only a few decisions away from what we want. Thank you.
Dear friends, on behalf of Survivors Against TB, it has been an absolute pleasure to host you for the India TB Summit 2021. The summit has brought together diverse voices and perspectives and has given us much to think about. It has provided valuable insights from all stakeholders, especially TB-affected communities and individuals, on how we need to reimagine TB care in India. Some of the things that have stood out have included the need for person-centered care, the need for innovation, and to make the TB care paradigm more holistic and comprehensive so that it includes the person's sociocultural and economic realities. As we close this summit, I'm reminded of something that an ex-XDR TB survivor from Mumbai said to me. She said, "You call this disease curable. We call it hell on earth." This should act as a sobering reminder to all of us on how far behind we are in meeting the expectations of those affected, and a guide to how far we need to go. I thank you all for the discussions, the debate, and the learning that has unfolded over the last 2 days. Your inputs and participation have made this event a resounding success. In particular, I want to thank our chairs who put together and curated an exemplary program, our survivors who led from the front and guided our discussions from the start, and to the exceptional management team that executed this event in record time. We will continue to discuss, debate, and learn from each other. TB affects us all, and this battle can only be won if we come together to defeat it. We hope to see you soon. Take care and be safe.